start the recording? Yeah, Monica ma'am, please go ahead.
Yeah, so we welcome everyone today to the ICOG FOXY certificate course on medical disorders in pregnancy, day 3, that is 27th of June, 4 p.m. We are starting day 3 today, and we have got a wonderful galaxy of speakers ready for you, a very dynamic interactive panel. Before we start this uh, today's episode consisting of 2 sessions of 3 talks each, I would request our convener, Dr. Achla Batra, to give us a preview of the previous day's talks.
Hello, good evening.
Good evening, ma'am.
So today is the third day of the very interesting and very informative certificate we had on the medical disorders of pregnancy. The first day, convener Dr. Charmila and coordinator Dr. Neha Tandon. It was a very, very informative session on hypertensive disorders in pregnancy, and we had stalwarts like Suchitra Pandit and Dr. Alpesh, who was the president and is Dr. Alpesh now, and very good insights into hypertensive disorders, followed by a panel discussion. Yesterday, on the second day, we had a hyperglycemia in pregnancy, the whole day dedicated to that. And it was really very insightful, all aspects of hyperglycemia, from oral hyperglycemia, medical nutrition therapy, insulin therapy, and preconceptional counseling, and a panel which covered everything was there. So I think everybody must have really benefited. And today, on the third day, we have important few topics because everything cannot be covered. So we have SLE, APLA, thyroid disorders in pregnancy, psychiatric disorders in pregnancy, chronic kidney disease, and a panel on DVT, which will be moderated by Sheila Mani. So I think it's going to be really great for the listeners and whosoever has joined it. And before we start our scientific program, I would like, a very enthusiastic and always encouraging everyone, our chairperson, Dr. Parag Puniwala, to say a few words. Dr. Parag, please.
Parag, I think you're on mute. You're not able to unmute, huh?
Yeah, now I'm able to unmute. Okay, good evening. And I bring greetings from ICOG and welcome to the third day of certificate course on medical disorders in pregnancy. I'm happy to share that there are more than 1,600 registrations for today, and I'm looking forward to some exciting learning experience today. I must appreciate the efforts put in by all the conveners. Dr. Achla Batra, who's the convener today, ably supported by Dr. Monica Singh as coordinator. And of course, we had Dr. Charmila and Dr. Komal Chauhan as conveners on the first and the second day. My best wishes for the program and happy learning. And I welcome our Vice Chair-elect, Dr. Sadhana Gupta, and welcome back Dr. Sarita Bhalerao, who's back in action from RCOG conference. Yeah, thank you.
So thank you, Dr. Parag. I would like Dr. Sarita, our ICOG secretary, very gentle but always working. Dr. Sarita, please say a few words for the.
Thank you, Dr. Achla. And it gives me great pleasure to welcome all of you for this program. I think this program is doing really phenomenally well with more than, I thought it was 1,500 and now Parag says it's 1,600 registrations. So that's really, really a big, big congratulations to all the conveners and the coordinators. I know that Dr. Charmila, Dr. Achla and Dr. Komal have put in tremendous efforts from, deciding the program, calling up all the faculty, ensuring that all the faculty are there, and also Dr. Monica, Dr. Neha and Dr. Jairani have really worked very, very hard for this program. So with that, I just take this opportunity to tell everybody who's joined in that we please do log on to the ICOG website. Please do get your FICOG in Delhi. And we have many, many exciting programs also in the month of July. So including a certificate course in the last week of July. So please do log on to icogonline.org. ICOG. Thank you.
So I'm very happy to see Dr. Sadhana, Vice Chairperson-elect of ICOG, a very dynamic leader. So, Dr. Sadhana, would you please say a few words for the...
Thank you, Dr. Achla, and my regards to Dr. Parag, Chair ICOG, and Dr. Sarita, Secretary ICOG. And it is a great leadership that we are doing one after one, wonderful programs. So congratulations to Dr. Charmila, Komal, Dr. Achla Batra, and Dr. Monica, Dr. Jairani, and Dr. Neha as a convener. And we are seeing their great effort in putting, and we know that how much effort it brings to put all the topics and the faculties together pan-India. So I welcome all office bearers, all faculties, and all participants, and it has been the phenomenal registration, 1600, and that speaks volume that how medical disorders are intersecting pregnancy, and we are having more and more diverse medical situation because people are getting pregnant like chronic kidney disease or SLE. And this certification course will enable everyone to have a basic understanding and the clinical approach and the multidisciplinary approach. So this is something that now we are talking a lot of multidisciplinary approach, but the important thing is that has to be focused, and it is not should be the fragmented. And that's why in India we have the issues that it become fragmented. We have not that dialogue across the discipline, and such type of course gives you a lot of understanding and how the physiological changes overlap the pathological issues and what are the obstacle causes.
Madam, your network has gone.
Yeah, I think her network has gone. It'll come back.
Right.
Anyway, thank you, Dr.
Yeah,
Sadhana. So
Yeah.
now I would ask Monica Jindal, my very energetic coordinator, who's really worked hard to connect with everybody and collect the questions and done everything wonderfully. She is the president-elect of Bhopal Society, and she has been the founder, president of ISOPAP in Bhopal also, and many more laurels to her credit. So Monica, over to you to carry the scientific program forward.
Thank you so much, Achla ma'am. And my regards to Chairperson ICOG, Dr. Parag sir, and Secretary Madam, Dr. Sarita Madam, and Vice Chairperson-elect Dr. Sadhana Gupta Madam for their kind and gracious presence. So without wasting time, we start session 1 of the dynamic third day. And here we will walk you through hypothyroidism in pregnancy. The first talk to be taken by Dr. Anahita Chauhan, SLE to be taken by Dr. Jayam Kannan, and chronic renal disease to be taken by Dr. Kasturi Donimat. This will be the first session. And for this session, I invite the chairpersons, Dr. Fessy Louis and Dr. Ashwath Kumar. Dr. Fessy Louis belongs to Kerala, and he is a well-known name in the field of in FOXI, in ICOG, as well as in ISAR. He is holding the post of Director, Department of Reproductive Medicine and Surgery at Amrita Institute of Medical Sciences in Kerala, as well as he's been the FOXI Vice President in 21 and ISAR National Executive Member. We welcome you, sir. I also welcome Dr. Ashwath Kumar to chair this session. Dr. Ashwath Kumar is a very renowned laparoscopic surgeon and a gynec oncology specialist, professor in the Department of Gynecology at Jubilee Mission Hospital, Thrissur, Kerala, as well as very known name in ICOG, IAGE, as well as FOXI. Welcome, Dr. Ashwath Kumar, sir. So I invite our chairs to introduce Dr. Anahita Chauhan, who is our first speaker for the day, speaking on hypothyroidism in pregnancy. Are the chairpersons there, Nilima?
No, ma'am.
So I'll be introducing, ma'am. Achla, ma'am, with your permission, can I introduce, madam? Good evening, Anahita, ma'am. It's a pleasure to welcome our speaker who will be taking the first talk of the first session today on day 3 of ICOG FOXI course. Madam is honorary consultant Saifi Bhatia and St. Elizabeth Hospitals in Mumbai, former professor unit head at St. GS Medical College and KM Hospital Mumbai, and past president of MOGS in 23-24, as well as the assistant editor of Jogi. We welcome you, ma'am, for taking the first talk.
Thank you. And give me a minute to just check that my slides are on. Give me 1 minute.
Sure, ma'am.
I'm just so sorry, but share screen. I'm so sorry, but it's not allowing me. Give me 1 second.
Technical team, please help Dr. Anaita.
Yeah.
मैम
Yeah,
मैम आपका पीपीटी फर्स्ट ओपन करके रख दीजिए.
I've opened it.
मिनिमाइज कर दिया मैम. फिर आप शेयर पे जाइए.
1 second. I've opened
क्लिक
it.
द शेयर बटन.
Just 1 minute.
यस मैम.
I can't minimize my screen. That's the problem.
मैम क्लिक द शेयर बटन.
I can't see anybody and I can't see anything except my screen now. 1 second.
यस.
Yeah. Can you hear me?
Yes, yes,
You can hear me and see me?
yes, ma'am.
You can't see my presentation. I think now I'll click the share button, but it's not allowing me to share. I think you'll have to take another speaker while I use another laptop. I'm so sorry, but possible.
Can we start Jam Kanan?
1 second.
So, Dr. Nilima, have you enabled that sharing for Dr. Anaita?
Yeah. We have made her videos.
Right. So let us play Dr. Jayam Kannan's presentation then, which is there with us.
Yes,
Please,
Shreya.
please.
Yes, ma'am. Yes, ma'am.
I think that will be better. I'll try to get another laptop in the meantime.
Sure, madam. So we will do the other presentation at present. And I think Dr. Fesilu is joining. He will be introducing Dr. Jayam Kannan.
Ma'am, sir join नहीं हुआ है.
Yeah, I just called him. He said he's joining. So,
Share record. Yeah. Ma'am, recording share करूँ? Yes.
you don't want to share the CV, Dr. Jayam Kannan's CV?
Sharing.
Yeah, just show her CV once so that we can, introduce our speaker. Speaker number 2, Jayam Kannan. Yeah. Good evening, Fesi sir. Welcome to Foxy ICOG certificate course on medical disorders in pregnancy. Good evening, Fesi sir.
Good evening.
Sir, we are starting with a recorded session by Dr. Jayam Kannan, who has recorded her video and sent to ICOG office. Kindly introduce the speaker, sir.
Good evening to you all. 1 second. I think welcome again for this Foxy ICOG certificate course on medical disorders in pregnancy. Today is day 3. We have got this is a session 1, and we have three speakers, Dr. Jayan Kannan, Dr. Anihita Chavan, and Dr. Ashish Mukhopadhyay. And Jayan Kannan Madam is Emeritus Professor Tamil Nadu MGR University, Chennai. Madam was Vice President of FOXI of 2018 and partner in maternal child health WHO since 2008. President of Indian Medal for Outstanding Performance in MBBS during MBBS time, and winner of 13 medals and prizes in MBBS, and also winner of RCOG Distinguished Service Medal in 2018, and first Indian to receive for outstanding community and medical services. And also 2025, Madam received the FOXI Legends Award. Over to you, Madam, for the session on SLE.
Very much for giving me this opportunity in this ICOG CME to speak on systemic lupus erythematosus in women, a management, especially in the reproductive lifetime that is required. The alternative names suggested for systemic lupus erythematosus are disseminated lupus erythematosus alone, butterfly lash SLE, and discoid lupus erythematosus. The flow of this presentation will continue with the overview of systemic lupus erythematosus, pathophysiology, SLE impact on women, diagnosis, management strategy, living with SLE a happy time, and management, especially in pregnancy. As such, the disease is an autoimmune disease. It's a chronic multisystemic disease with variable symptoms. Of course, no cure at all. Manage the symptoms only. The autoimmune disease is also characterized by the immune system attacking its own body, own tissues. Prevalence is higher in special ethnic groups, including African, American, Hispanic, and Asian women. Apart from the immune dysfunction, genetic predisposition is also a dominant factor. The causes of SLE are genetic, environmental, hormonal, and certain medicines also. It affects women 10 times more than men. Appears in the age group of 15 to 44, which is the prime life of a woman suffering with this disease, going in the open air with a butterfly flare is sometimes so distressing for a woman also. The pathophysiology in these cases, as we all know, the immune system mistakenly attacks the healthy tissues. The healthy tissues go into inflammation and damage and destruction. Certain genes can increase the risk of developing the disease also. Family history of SLE is also a contributing factor. Environmental factors such as sunlight exposure, infections, and certain medications trigger or exacerbate SLE. Recognizing these triggers is important for effective disease management. Women are disproportionately affected by SLE. 90% are diagnosed in females. This gender disparity necessitates a focus on women's health issues, especially in relation to SLE. The mental health is exorbitantly affected in women with SLE. They are not able to carry out their own activities. More so, hormonal changes during menstruation, pregnancy, and menopause can also influence the disease in SLE women. Now coming to SLE in pregnancy, it is a unique challenge during pregnancy with increased risk of complications right from early trimester to the delivery, end of the delivery and postpartum also. Management of complications of SLE in pregnancy will require attention on preeclampsia, preterm birth, lupus flares, increased risk of blood clotting, miscarriage, worsening of the lupus erythematosus also. The fetal complications include fetal growth restrictions, premature birth, neonatal lupus, fetal loss. Presence of the neonatal lupus adds extreme mental health complications to the entire family also. The common symptomatology expressed in SLE depends on what is the organ that is affected. More so, they are always in fatigue, joint pain and stiffness, skin rashes in bright colored women. In dark colored women, it may not be a big problem. Especially in Indian copper hue, it may not be a big problem. Skin rashes are always unavoidable. Fever now and then puts the patient for hospital care very much. Photosensitivity is another important issue, especially in women who are whitish and pinkish. Kidney problems, lupus nephritis, if it is there, it gives rise to life-threatening problems. Also, lung issues leading on to pleurisy and pneumonitis, neurological problems, and blood disorders with blood counts and its problems. Other common symptoms also include, depending on the system that is affected, with the CNS and brain, headache, weakness, numbness, tingling, seizures, vision problem, memory, and personality changes also. With the digestive tract problem, it can lead on to abdominal pain, nausea, vomiting, and subacute paralytic ileus also. In the heart, it can lead on to valve problems, inflammation of the heart muscle leading on to cardiomyopathy, or the pericardium resulting in pericardial effusion. Lung, building up of the fluid in the pleural space can lead on to pleural effusion. The involvement of the endothelial tissue lead on to difficulty breathing, and sometimes can also, women may cough out blood also. Skin, apart from the external skin, sores in the mouth are also commonly seen. The kidney problems earlier manifest with swelling in the legs, later on with due manifestation of the renal disorder depending upon the extent. Blood circulation, clots in the veins and arteries, inflammation of the blood vessels, constriction of the vessels, and response to cold, altered response to cold, what is called Raynaud's phenomenon, is also a very, very characteristic feature. Blood abnormalities include anemia, low white blood cell count, or platelet count also. The basic tests required in these patients are antinuclear antibody, total blood count with differential features, X-ray of the chest, serum creatinine, and total urine analysis also. Apart from this basic test, rheumatologists also come out with series of tests, antinuclear antibody panel, complement components like C3 and C4, antibodies to double-stranded DNA, CRP, C-reactive protein, Coombs test direct, cryoglobulins, ESR, and go for total, kidney function test, liver function test, rheumatoid factor, APLA antibodies, lupus anticoagulant test, not to be thinking less about kidney biopsy, imaging test of the heart, brain, lungs, joints, muscles, or intestines also. The management, of SLE in general, in women, depends on how active the disease is and what part of the body is affected and what form of treatment is required also. If you have a mild SLE, the non-steroidal anti-inflammatory drugs for joint symptoms and pleurisy may be enough. Low doses of corticosteroids such as prednisolone for skin and arthritis symptoms also. Corticosteroid cream for skin rashes also. Hydroxychloroquine may be required even lifelong. Methotrexate may be used when we want to reduce the dose of corticosteroids. Belimumab, rituximab, and anifrolumab are biologic medicines that may be helpful only in some people. If you have a case of severe SLE, it requires high dose of corticosteroids, immunosuppressive medicines, and these medicines may be required only in cases where they are not getting better with high doses of corticosteroids. Nervous system, kidney, or other organs, if they are affected, may be requiring immunosuppressive medicines. Mycophenolate, azathioprine, cyclophosphamide, and valcospirin are commonly used in cases of severe SLE. Because of the heavy toxicity, cyclophosphamide is limited only to a short course of 3 to 6 months. Rituximab may be used in some cases. Blood thinners like warfarin may be used for clotting disorders, especially in patients with antiphosphorylated antibody syndrome. The common measures which are required in these patients are wear protective clothing up to wrist, up to ankle. Wear always sunglasses when we are going in sun. Sunscreen liberally to be used with a good percentage when you are walking in the sun. Get preventive heart care now and then. Stay up to date with all immunizations which are being currently prescribed then and there. Alter it as per the requirements. Always be on influenza care whenever there is an epidemic. Always have tests to screen for thinning of the bones, that is osteoporosis. Please avoid tobacco and drink minimal amounts of alcohol, which is not much in Indian scenario, may be there in the Western scenario. Frequent antenatal, especially in cases of pregnancy, what we have to do with the SLE pregnancy, right from the beginning, frequent antenatal visits, not resting on to 4 visits as per WHO standard, along with the rheumatologist care then and there, and high risk obstetrician. It is not a case to be dealt with by a young budding obstetrician who has recently passed out in her college. Hydroxychloroquine is generally confirmed throughout pregnancy. Low-dose aspirin is always started in the first trimester to prevent preeclampsia. Corticosteroids also may be used to manage the flares now and then. Lowest effective dose is preferred. Antenatal corticosteroid, yes. Medications like methotrexate and mycophenolate, myofril, all these things to be avoided in pregnancy. In pregnancy, preconceptional counseling adequately, monitoring then and there frequently, medications, see that it is taken. Lifestyle is always kept possible. Early detection of complications with multidisciplinary approach liberally and timely delivery in these cases with prompt adequate neonatal care is what is required in these patients. Prognosis of these cases has been improved in the recent years. However, many have got mild symptoms. How well they recover depends on how severe the disease was. They always require minimum drugs for a longer time. All will require hydroxychloroquine. In the United States, SLE is one of the top 20 leading causes of death in females between the ages of 5 and 64. Hence, Lot of research is going on, especially for the first year after diagnosis and in people who are young. Thank you very much.
Hello. Hello.
Hello.
Yes, sir. Yeah.
Yes. I think
I think the video is still playing, Nilima.
No, ma'am. It
Or
has finished. Yeah.
video has finished. So, Fasi sir, we have finished the first talk of session 1. This was the first talk on SLE by a recorded session by Dr. J.M. Kannan. And sir, you can proceed with the introduction of our speaker number 2.
I think we will have the next talk. Can you
Yes.
hear me?
Yes, sir. Yes, sir. We can hear you, sir. Kindly
Next,
Dr. Anahita Chauhan.
yes. Next, we have talk on hyperthyroidism in pregnancy. We have Dr. Anahita Chauhan. Can you show the CV of Dr. Anahita?
Fesi, I've already been introduced, so don't worry about it.
Oh, okay. But still, I think.
Yeah. I'm just trying to share my screen. Can you see the screen now?
Yes, yes.
Okay, perfect. Thank God.
Make it into.
Yeah, I'll just make it into slider show. Right?
Yeah.
Yeah.
Yes.
Okay. I'm so sorry for the delay and thank you for bearing with me. So I'm going to talk about hypothyroidism in pregnancy, and I'm not going to spend a lot of time on the basics of why pregnant women are more hypothyroid, etc. And since I have only 15 minutes, I'm going to do a lot more about the treatment part of it and the newer guidelines. But we'll start with the introduction and background. And I don't feel that we need to focus that much on hypothyroidism per se. It's actually the difficulty comes when it is subclinical hypothyroidism and how to differentiate and treat patients with subclinical hypothyroidism as well as overt hypothyroidism. So we all know that the prevalence is 1 in 10 people in India do have hypothyroidism, and this is higher than the Western prevalence. And it is obviously 3 times more common in women. What is subclinical hypothyroidism? It's a biochemical diagnosis. Basically, patients with subclinical hypothyroidism can be categorized as mild, where the thyroid or the TSH is mildly elevated between 4.5 and 10, and others who have markedly increased TSH, which is more than 10. However, the T3-4, the free T3 and the free T4 are essentially normal. Now, when we have to differentiate between subclinical and overt hypothyroidism, this slide becomes very useful. That when we see subclinical hypothyroidism, it is with normal free T4 ranges, but the TSH range is 4.5 to 10. And these patients are typically asymptomatic. In overt hypothyroidism, of course, they have more than 10 TSH and they have all the symptoms like fatigue, weight gain, cold intolerance, etc. So it's important to differentiate subclinical hypothyroidism from other causes and symptoms such as age, which is associated with a rise, or non-thyroidal illness, sometimes a lab assay which may be wrong, adrenal insufficiency, chronic renal failure. All these can also temporarily elevate the TSH. So it's important that we take a proper history. Coming to the etiology of subclinical hypothyroidism, almost 1 in 12 patients will suffer in India from subclinical hypothyroidism. And this range in pregnancy actually is widely reported between 3.4 and 32%. In fact, there are many, many studies, And the largest of these, which is Yadav et al., has said about 10% as the range. So 2 to 5% of patients with subclinical hypothyroidism will progress to overt hypothyroidism. And an Indian study documented that almost 18% of patients will develop hypothyroidism postpartum. So it's not only preconception that we have to be alert, but we have to follow these patients through the pregnancy and also postpartum. And this progression is shown here that within 1 year, if the levels are low, the progression is about 15% within 5 years postpartum to overt hypothyroidism. Whereas if the levels are high to begin with, the progress is as much as 30% in the first 5 years postpartum. Coming to the thyroid antibodies. Now, these TPO or thyroid peroxidase antibodies or thyroglobin antibodies are positive in up to 18% of all pregnant women. And also, an Indian epidemiological study showed that these antibodies are positive in 40% of hypothyroid pregnant women. So, should we rely on this? I think it's very clear from many of the guidelines that the first thing that we should rely on is the TSH of the patient. So just a slide or two about the pathophysiology. Basically, we all know that pregnancy is a natural stress for the thyroid gland, and because of increased estrogen, increased thyroid binding globulin, the total T4 does go up 1.5 times. Similarly, because of the structural similarity between HCG and TSH, there is a transient fall in the TSH at 8 to 14 weeks. Similarly, because of the increasing plasma volume, overall the demand of T3 and T4 goes up almost 50%. There are many mechanisms leading to subclinical hypothyroidism, starting with iron deficiency or excess, autoimmune thyroiditis, and the HCG influence, but that's not my point of discussion today. So today we are going to look basically at how to look and clinically evaluate and treat a patient of hypothyroidism. So now we'll come to the diagnosis and the risk factors. So we know that there are numerous risk factors, including geographic area with iodine insufficiency, personal or family history, older patients, patients who have got positive thyroid antibodies, type 1 diabetes, other autoimmune disorders, pregnancy complications like preterm delivery, miscarriage, infertility, prior or current use of amiodarone or lithium, some patients who are morbidly obese, and those who have had a head or neck radiation exposure. These are the common risk factors for developing hypothyroidism in pregnancy. And the clinical symptoms are important to note because subclinical hypothyroidism is asymptomatic most of the time. I cannot overemphasize this because when we tell patients that, oh, you do have a thyroid issue and you will require treatment, many of them say, but doctor, I don't have any symptoms. And even if they don't have symptoms, they do require treatment. Of course, the common symptoms with overt hypothyroidism are puffy face, reduced hearing, a goiter may or may not be present. They're typically constipated, they have muscle cramps and fatigue. They may have neurological and psychological issues. They may have cardiac issues, especially bradycardia or pericardial effusion, and they may have paresthesia and brittle nails. Now, we don't typically see this in pregnant women because we are most of the time dealing with subclinical hypothyroidism. So what are the laboratory criteria to clinch the diagnosis? Now, here I have put the ITS, that's the Indian Thyroid Society, the European as well as the American, but it's important for us to remember the trimester-specific TSH reference range, and remember, first trimester 2.5 or less, second trimester and third trimester 3 or less is okay. Anything more than that, you should be on guard. So the ITS consensus statement says that the range in the first trimester for free T3, free T4 and TSH can be up to 3.6. This is the newer consensus statement, but trimester-specific hormone reference intervals should be established locally due to variations in ethnicity, iodine status, assay methods, etc. And if the local ranges are unavailable, an upper limit of 4 in the late first trimester should be a warning. If the TSH concentration is outside the pregnancy reference range, then T4 measurement should be done, and that is free T4. In case you cannot do a free T4, then the T4, total T4 should be multiplied by 1.5 times. In women with known thyroid antibodies, the concentration should be assessed of TSH every 4 weeks up to the mid-trimester, and then again once at 28 weeks. So what are the effects or the impact of this hypothyroidism on pregnancy, and what are the risks with subclinical hypothyroidism? So basically, we know that the risks with subclinical hypothyroidism begin way before pregnancy even starts. Pregnancies in women with subclinical hypothyroidism are 3 times more likely to be complicated with placental abruption, twice as likely to have preterm births, and the miscarriage rate is also twice that of euthyroid women. So overall, 2 to 3 times increased risk of pregnancy complications in untreated women with subclinical hypothyroidism. This slide is a composite of all the effects on the mother, the fetus, as well as the neonate. And the mother will suffer from anemia, preeclampsia, placental abnormalities, as I already said, postpartum hemorrhage, and myopathy. The fetus, if left untreated, will have cognitive impairment and neurological abnormalities, may also have developmental abnormalities and congenital hypothyroidism. And the neonate may have hyperbilirubinemia and respiratory distress. This is just a summary of all the studies that have been done on the maternal outcomes and on the neonatal outcomes. I'm not going to go in the details of all this, but it's important to understand poor Apgar scores, respiratory distress syndrome, and perinatal deaths are commonly associated with subclinical hypothyroidism. One important point is hypertensive disorders of pregnancy, and this is a great meta-analysis which evaluated the relationship between subclinical hypothyroidism and HDP, and this included more than 1 lakh patients. And there's definitely an increased risk of HDP in pregnant women, especially with a TSH of more than 4. And subclinical hypothyroidism in any trimester increases the future risk by HDP by 1.5 times. Which brings me to the main part of my talk, and that is the management strategies and the goals of treatment. Now, obviously, we as gynecologists are initially scared to prescribe levothyroxine. We are scared to tell the patient directly, and we do tend to refer to an endocrinologist. But I want to say that if you do have a patient of hypothyroidism or subclinical hypothyroidism, it makes sense to directly start treatment. What are the goals of treatment? The goals of treatment are that you must start levothyroxine because it is effective, safe, easy to use, and cheap. And your goal should be less than 2.5 for women planning to conceive or for women in the first trimester. You want to restore the euthyroid state, relieve any symptoms, and avoid overtreatment. So coming to the ITS and the FOXY 2019 recommendations, obviously, if any patient has a TSH of more than 10, irrespective of the antibody status, you will start thyroxine. Similarly, if the patient has a TSH of more than 4 and her antibodies are positive, you will start thyroxine. If the TSH is between 4 and 10 with negative antibodies, you can still start thyroxine, and between 2.5 and 4, you should first do the antibody status and then start thyroxine. So it can be considered. The reason we are actually emphasizing so much on hypothyroidism is that when we see women with hypothyroidism, if we don't treat them, their child will be a hypothyroid, subnormal cretin. And these are actual words which I'm using so that it is in all our minds that these women need to be treated. So the treatment plan is in the first trimester, less than 2.5, and in the second and third trimesters, less than 3. This is a table which just shows the ATA guidelines as the American Thyroid Association and the latest RCOG guidelines as well. And that's the same thing that they say, that where the TSH is high or where TPO antibodies are present, please begin levothyroxine. The recommended dose to begin is 1 to 1.2 micrograms per kilogram body weight per day. And those with a higher TSH, you should start with a higher dose. So here we have a patient who maybe you have started on a dose of 25. Yeah, I'll take just a minute or two more. Yeah. So if you've started as a dose of 25, you may increase it to 50 after 6 weeks based on the TSH. And if in the second or the third trimester, you've started on a dose of 25 and her TSH is more than 3, you could increase the dose to 50. And similarly, by 25 microgram increments, you should increase the dose. At any time, if the TSH is less than 0.1, you should start again decreasing the dose in increments of 25. Similarly, for the adjustment of the dose, if it's 25 micrograms increase, between 5 and 10 TSH 50 micrograms, between 10 and 20, 75, and so on. So after the pregnancy is done, there is also a high risk of postpartum hypothyroid, and you have to aim to bring the pre-pregnant dosage back. You have to if the LT4, that's the levothyroxine, was initiated during pregnancy, you should discontinuing if the dose is less than 50 micrograms per day, and evaluate again the TSH at 6 weeks postpartum. So just a word that we all believe that universal screening is recommended given the high prevalence and the adverse effects of thyroid disorders, and targeted screening should not be relied on. So we should be relying on universal screening. I'm going to skip the clinical scenario, but I'm going to go to the conclusions and the key takeaways. Diagnose and treat thyroid dysfunction during preconception and pregnancy. Consult with the endocrinologist in case of an abnormal thyroid profile, only if required, and manage thyroid function during pregnancy according to the trimester-specific TSH cutoffs recommended by the international and national guidelines. Thank you.
Thank you, Madam, for that wonderful talk on that. Especially there is always some ambiguity in about what is the value of thyroid, how do you do it. We'll take the questions at the end of the next talk. One more talk is there. That is, we have Dr. Kasturi Donimath talking about the chronic renal diseases. And Dr. Kasturi is the immediate past president of Kasoga, Karnataka State Obstetrics and Gynec Association, President in 2022, Professor and HOD, Department of Obstetrics, Kim Subli, ex-President of HDOGS, that is Hubli Gynec Society, ex-Secretary General, Principal Investigator for International Research Project, MCA Inspector to colleges all over India, undergraduate and postgraduate examiner at many universities, Chairperson of Graduation Committee of Kim Subli, TOT trainer, faculty at many state, national, and international conferences. Also a Rotary member. Conducted Jana Harsha Kayasoga PGCME for last six years. She is conducted many workshops, CME conferences, contributed many chapters. Over to you, Dr. Kasturi, for the
Thank you so
talk
much.
on Dr. Chronic Renal Disease.
Yes, sir. Thank you so much, sir, for your kind words. Very happy to be a part of this CME. I'll just share my slides.
Meanwhile, you can give the questions for the question answers you can put in chat box.
Yeah, and Dr. Anahita, you can answer the questions on the chat box only. That will save time and people can read also the questions.
Sir, my slides are seen?
Yes, yes.
Okay. Just okay. So thank you
Yes.
so much, sir, for this nice introduction, and thank you full ICOG team, Dr. Parag sir, and the whole team for inviting me for this. Today I'll be talking about chronic kidney diseases in pregnancy. I know it's quite a rare condition which we don't see routinely, but we need to know because nowadays in the past we hardly used to see such complicated cases like CKD in attempt, but now the survival is improving because of the good renal replacement therapies. The CKD patients have got good survival and they are attempting pregnancy. So nowadays we are seeing cases of CKD with pregnancy. So the most common causes what we routinely find are hypertension, diabetes, and glomerulonephritis, though other causes are also there. And nowadays we are seeing it more because of more people are diabetic and hypertensive and they end up in CKD. And also they are delaying the pregnancy, the delayed age and delaying pregnancy also is one of the cause why we are seeing more of such cases. So the common conditions which we do see routinely are nephrotic syndrome, chronic glomerulonephritis, renal failure due to either chronic nephrolithiasis or nephritis, diabetic nephropathy, and renal atherosclerosis. Now, what is the definition of CKD? Whenever there is presence of kidney damage, which is detected as urinary albumin excretion of more than 30 milligram per day, or if we find GFR of less than 60 ml per minute for 3 or more months, then we label it as CKD. Now, in this CKD also, KDOK classification of CKD is there. In that, there are 5 stages. Stage 1 is like the GFR is normal or more than normal, that is more than 90, but there is a kidney damage. Or kidney damage with mild GFR, reduced GFR, that is between 60 to 89. Moderate is between 30 to 59, and severe is 15 to 29. And very severe end-stage renal disease less than 15, and where patients are on dialysis. So this is a simple classification where we can understand. So the end stage 5 is that is less than 15. So stage 4 and 5 are very bad for pregnancy. The outcome is very, very bad in 4 and 5. 1, 2, 3, it is manageable. So another way of looking up the CKD is mild renal impairment, moderate and severe, depending upon the creatinine values. That was according to the GFR and albumin levels. This is according to the creatinine values. So if it is creatinine is less than 1.5, then it is a mild renal impairment. 1.5 to 3 is moderate, and more than 3 is severe renal impairment. Now, what are these pre-pregnancy factors which will predict the outcome during pregnancy? So, if degree of renal impairment, depending upon her creatinine values or eGFR, etc. Other is degree of proteinuria and degree of control of hypertension pre-pregnancy, that will determine the outcome. So, if you see, as I was telling, the creatinine, so if a creatinine is less than 1.5 pre-pregnancy, before becoming pregnancy, the live birth rate is in more than 90% of the cases. But if the creatinine is between 1.5 to 2.5 preconceptionally, then live birth is around 85%, but with the condition that her BP should be well controlled. But if a BP is not well controlled, then we don't get the live birth rate of 85% if the creatinine is 1.5 to 2.5. And if the creatinine is more than 2.5, the fetal loss is very, very high. This is very high risk that should be explained to the patient. Then what are the physiological changes during pregnancy, renal changes? One is renal size increases by 1 to 2 centimeters. Urinary tract, there is physiological hydronephrosis during pregnancy. There is urine protein excretion that is 150 to 250 milligram per day. Especially in twins, it may be more. And creatinine, others, non-pregnant, we take 1.5 to normal, 1.2 normal. But in pregnancy, it is 0.8. So something more than 1, we should be at alert in pregnancy. So there is increased renal plasma flow, increased GFR by 40 to 50% in pregnancy, and decreased serum creatinine and urea. So we cannot take the non-pregnant values in pregnancy. And there will be mild glycosuria. So sometimes for when we diagnose for GDM, we should not take urine sugar as a criteria, only the blood sugars. So because there is physiological mild glycosuria in pregnancy. So these are some of the changes which occur in kidney during pregnancy. Like in hemodynamics, as I told, increased renal blood flow, increased GFR, afferent and efferent arterial vasodilatation, maybe due to the relaxin and progesterone hormone secreted by the placenta or due to nitric oxide. Second is pelvic LSL dilatation, hydronephrosis, I told. Then tubular function, increased glycosuria, increased calcium excretion, and increased reabsorption of uric acid. Endocrine, increased erythropoietin, increased RAS, and systemic changes, sensitivity to RAS, increased water retention. So only edema will be there in these patients. So what is the maternal risk? The greatest concern in this is mother is because of the renal function and because of the cardiovascular complication. So what will happen during pregnancy is there will be worsening of a renal function, which was there. Increased incidence of infection, that is pyelonephritis is there. Increased proteinuria, worsening of the edema. Definitely she will develop preeclampsia, and or she may be having she will be having pre-existing hypertension. On that she will develop superimposed preeclampsia, and definitely there will be volume overload, and she is anemic, and very, very high risk of progression to end-stage renal disease, that is ESRD, end-stage renal disease. Now, what are the fetal risk when the CKD patient becomes pregnant? I told you the risk is highest in stage 4 and 5, but 1 to 3 we can still manage, but still they will have bad outcome, like baby may be IUGR. There are lots of preterm birth, both spontaneous and induced because of the hypertension and the other complications. And there will be oligohydramnios, stillbirth rate is high, and also the neonatal complications. Now, how to go about it? If a CKD patient becomes pregnant, before she becomes pregnant, to address her to preconceptional care and the counseling is extremely, extremely important. So before she becomes pregnant, we should have baseline evaluation of her, like complete blood count, full renal function test, electrolytes, everything, liver function test, detailed urinal, then spot urine protein creatinine ratio, 24-hour urine protein, all the blood glucose, HbA1c, etc., blood pressure measurements, what medications she is taking, whether they are teratogenic. If they are teratogenic, we should switch on to non-teratogenic drug in the preconceptional period, and baseline renal ultrasound. So this baseline evaluation preconceptional is very important. Once you do baseline evaluation, then you should triage these patients. Triaging means risk stratification you have to do, and tell them, the patient, that you explain them everything. What will be the morbidities to her and to the baby, and all the thrombosis risk, infection risk, and developing hypertension, everything you explain in detail. Informed shared decision should be taken. And after explaining everything, if she wants to continue pregnancy, she will be under strict surveillance during the pregnancy. If she doesn't want to continue after hearing all the problems, then contraception should be offered. What contraception? You can offer a LARC or permanent method sterilization, or short term, even the DMPA, etc., or progesterone only pills can be offered. Now, what is the maternal surveillance? Here, more frequent visits. ANC visits will be every 2 weeks from day 1 only. It's not every 4 weeks. And after 28 weeks, it will be weekly. And you have to repeat the investigation more often here. Renal function test, proteinuria, bacteriuria, GDM screening, everything will be more frequent in this patient. And fetal surveillance also more frequent. And one problem here is the interpretation of the results like quadruple test or double marker, because here there is increased increased beta HCG because of the renal excretion is more. So false positive, you can get it. Or you can offer a NIPT and more frequent growth scans. And right from 28 weeks, more frequent growth scans she will need. And you have to put her on Ecosprin 150 milligram HS from 12 weeks to 36 weeks. Nutrition, good nutrition advice. And then anemia should be corrected. If needed, erythropoietin can be given. And hypertension well controlled with labetalol, nifedipine, methyl-dopa. And if there is gross edema and reduced GFR, you can offer diuretics also. And many patients will need thromboprophylaxis. So the impact of CKD, it all depends on the severity. I told you, stage 1 and 2, favorable outcome. Stage 3, very high risk of hypertension preterm. And 4 and 5, very high maternal and fetal mortality. So preconceptional counseling, very, very important. So just review the drugs which she is taking. And if any nephrotoxic drugs are there, then you have to change. If any teratogenic drugs, you have to change. So good counseling and is very important. And then investigations. I told you, detailed renal function tests and renal ultrasound and spot and protein creatinine ratio, very important, you have to do. And in needed cases, you can do autoimmune screening. So the management principle here is both maternal and fetal well-being. Along with that, maternal renal protection should be your aim, not just looking at the baby and the mother. And it is definitely multidisciplinary care, involve a nephrologist, nutritionist, and a senior gynecologist while managing these cases. And hypertension, as I told you, preferred drugs are labetalol, nifedipine, and methyl-dopa. But now methyl-dopa is not available. Avoid ARBs and ACs. They are teratogenic. And salt restriction and fluid balancing is very, very important. And proteinuria monitoring and management is also important. If there is too much proteinuria, not this thing, then sometimes these patients may need biopsy, renal biopsy also. And regarding dialysis in pregnancy, pregnancy is possible if the patient is on dialysis. Yes, there have been reports where pregnant patients who are on dialysis or also have become pregnant, but the risk is very high, but they have found good outcomes. So if the patient is pregnant and her renal disease are increasing, the CKD is worsening, then she may end up in having dialysis. So if the GFR is less than 15 or if there are uremic symptoms, that's an indication for dialysis. And once they're on dialysis, it's not like other patients, not like once in 3 days or weekly twice or something. Here, these patients will need almost daily dialysis, and the number of hours she will need dialysis is also more. And the target should be less than BUN should be less than 50. And after dialysis also, we have to monitor the fetus very well. That is very important, monitoring the baby after every dialysis. And all this nephrologist will look into it. So what drugs and how he has to change a diacylate, all that very, very minor changes have to be done when a pregnant patient is on dialysis. And as I told you, they need more frequent dialysis, prolonged dialysis, and these dialysis patients are known for preterm deliveries. So, and perinatal outcome is little question, means when they are on dialysis, yes, some patients do have, but you should consult the patient that some patients can have problematic perinatal outcome. And once they are shifted back from dialysis to the ward, we have to monitor, we have to do NST and then monitor the baby. Very, very mandatory. Fetal monitoring after each dialysis is very mandatory because there is a shift in the fluids, acute shift of fluid shift is there. So very, very important. And she'll need more frequent growth scans and Dopplers regularly to look for any fetal compromise. And sometimes, as I told you, they end up in preterm deliveries. And if they deliver when they're on dialysis, baby monitoring is also very important, neonatal, because infants will experience the osmotic dialysis at birth. Hence, the electrolyte abnormalities can be there in the baby. So hypocalcemia, tetany is very common in newborn. when these patients, and also monitoring their electrolytes is very, very important. Electrolytes and blood sugar also. And these patients need additional dose of folate, vitamin C, all this thiamine, etc. have to be supplemented, and calcium supplemented also should be little more compared to, and fluid balancing is very, very important. And protein intake also you have to monitor. So management when they're on dialysis is you have to monitor their BP and their electrolytes, bicarbonate, potassium, and manage them. And some patients may be on peritoneal dialysis. But if the patient is on peritoneal dialysis and she becomes pregnant or she is pregnant, there is very, very high chances of preterm deliveries. Outcome is not so good as in hemodialysis. There is chances of peritonitis, etc. So better to shift this peritoneal dialysis to hemodialysis once they become pregnant. And what about kidney transplant? So nowadays, many patients are undergoing kidney transplant and the outcome is good. They're having good life and all after the kidney transplant. So almost their kidney functions would have come back to normal. So kidney transplant patients can plan for pregnancy. Only thing, it is safe if it is after 1 year or 2 years. I mean, if it is after a cadaver transplant, it is better to plan for pregnancy after 2 years of transplant. And if it is live transplant, then it is better to plan after 1 year of transplant. But you should assure that the stable graft is there and it is functioning well, and there should not be any no recent rejection. And what immunosuppression she is taking, that you should monitor whether they are teratogenic or teratogenic to the baby, and you should avoid that, and you can shift it to tacrolimus and azathioprine, which are quite safe during pregnancy. So the patients you should monitor the hypertension, plasma creatinine, and they'll be on steroids. So prednisone dose should be around 15 milligram, azathioprine, all these drugs. So close monitoring of these patients is necessary. And even these patients, vaginal delivery is possible, but if they undergo cesarean section, you should involve a transplant surgeon when you are doing cesarean, because there is altered anatomy. There will be pelvic kidney and altered anatomy. So you should involve a urologist or a transplant surgeon is better, because we should not cause damage to the kidney when we are operating. So that is a must. And after delivery also, pre-delivery, even after delivery also, the nephrologist should be seeing the patient continuously. They should be doing. And most of the time, these CKD patients are having anemia. So how do you manage this anemia in CKD patients? So we give erythropoietin. So erythropoietin is given whenever the HB is less than 10 grams or transferrin is more than 25, or ferritin more. That's an indication. So actual vital HB which we need is 10 to 11.5. But there are some problems due to erythropoietin, that is material thrombogenic risk is there, hypercalcemia, hyperphosphatemia, and some patients severe hypertension. So if the patient is uncontrolled hypertension, EPO is contraindicated. Indications for hospitalization in CKD patients is uncontrolled hypertension, preterm labor, IUGR, or again if there is acute kidney insult or injury, and superimposed preeclampsia. Timing of delivery, if everything is fine, you can wait up to 37 weeks. Vaginal delivery is preferred, and C-section only for obstetric indication. So the mode of delivery, vaginal delivery can be done, is preferred. So if on investigation, if she is very high risk, that is creatinine, GFR more than 25% with pulmonary edema, refractory hypertension, and if these patients are less than 24 weeks, better to terminate. If they're more than 31 weeks, also better to terminate. If they're between 24 to 31 weeks, you can offer them dialysis and control their BP and somehow extend up to 31 weeks, high risk. But if they're low risk,
I'm sorry to interrupt, ma'am. Time is over now. So kindly conclude the thought.
Postpartum period also just monitor the BP and avoid NSAIDs.
Thank you, Kasturi.
Dear President, Secretary, this letter is.
Thank you, Kasturi. I'm here as chairperson, Dr. Shobha Gudi, reporting here to ICOG. Yeah.
Yeah,
Hello.
summary,
Am
we
I
have to be
am I
close
audible?
monitoring and this, yes.
Yes,
So
ma'am.
only one thing you
Madam,
remember.
last talk of that session is going on.
Ma'am,
Yes.
kindly continue and conclude the talk, ma'am.
Yeah. Yeah, I'll stop there.
Chabagudi madam, please mute. Some background music is coming. Ah, yes.
Yeah.
Yeah.
yeah. Kasturi ma'am, you can conclude, please. Yeah.
Yeah. So this only thing to understand this, we have to look deep into the crosstalk between the kidney and the placenta. Then we can address the CKD properly. Thank you. Yeah.
Thank you, madam. I think we will quickly. Do you have time to take questions, Dr.
I
Monica?
think they can answer. Dr. Anahita and Dr. Gopinath can answer the questions in the chat box because there are many questions.
There
Otherwise,
are a lot of questions. All the questions, I mean, most of the people have asked about is whether if a TP antibodies is high, if the TSH is normal, whether to start the Eltroxin. And
Dr.
next is the,
can we let Dr. Anahita answer these questions in the chat box so that we can keep proceeding? And Dr. Kasturi, you also please answer the questions in the chat box. Only one question which I also wanted, why aspirin in hypothyroidism? Rest you can answer, all simple questions.
Beg your pardon?
Somebody has written why aspirin in hypothyroidism.
So I haven't mentioned that, but aspirin or rather ecospirin will help in preventing HDP. So not for any other reason that I have found, but for
Got it
HDP.
wrong. Somebody must have got it.
Yeah.
I think, Monica, we can.
I'll answer the questions in the chat box.
Yeah.
Yes.
Monica, you can thank our chairpersons and then.
okay, so thank you, Jayankarnan madam, Dr. Anahita and Dr. Kasturi for their excellent talks. Over to the next chairpersons for the second session.
As we conclude session 1 of our day 3 program of FOXI ICOG certificate course on medical disorders in pregnancy, I take this opportunity to thank our chairs for the first session, Dr. Fessy Louis sir, and Dr. Ashwath Kumar was caught up in OT, so he could not join. But Dr. Fessy has conducted the session brilliantly. And now we start the session 2, which again is consisting of 3 very good topics. Intrahepatic cholestasis of pregnancy by Dr. Shabana Sultan, Psychiatric Disorders in Pregnancy by Dr. Chandrika Anand, and APLA by Dr. Ashish Mukhopadhyay. To chair this session, I invite Dr. Shobha Gudi and Dr. Shanta Durge. I'll take this opportunity to introduce the chairpersons for session 2. Dr. Shobha Gudi is a well-known figure in FOXI and ICOG. Madam is a postgraduate teacher and examiner, chairperson of Family Welfare Committee of FOXI 19 to 22, and president of Bangalore Society of OBGY 18 and 19. She's also been the Secretary General of KASOGA in 25. She's still the Secretary General of KASOGA 25 to 27 and assessor of government.
Yeah. That's fine. That's fine. Yeah. Monica, you're muted actually. You're muted.
I'm so sorry.
No problem. So I think okay.
So Shobha Madam is welcome amongst us as chair for our session 1. Madam is ICOG Governing Council member as well as Secretary General of KASOGA.
It's okay. Monica, please go ahead, please. Yeah.
I would also like to introduce our session 2 chairperson, Dr. Shanta Durge. Madam has been nominated member to Karnataka State Supervisory Board of PCP Entity Cell, and she's director and chief consultant at Durge Clinic and Fertility Center at Basav Kalyan, and a recipient of Corion Award and Distinguished Community Service Award. We welcome Dr. Shanta. And I would request our chairpersons to kindly introduce the first speaker for the session 2.
Yeah, so shall I go ahead, Monica?
Yes, please, ma'am.
Yeah, Shanta, are you there? Shanta, are you there? I didn't see her.
She's about to join, ma'am. She's about
to. Fine. So I take great pleasure in inviting Dr. Shabana Sultan, and at the outset, let me thank the ICOG team and also the president, Dr. Sunita, and the chairperson, Dr. Parag, for inviting me here. And I'm really delighted to chair this session with the 3 unique topics that you just listed. So it's my pleasure to call upon Dr. Shabana Sultan to deliver the next talk. And she is Professor and HOD, Department of Obs Gynae, GMC Bhopal. She has been the organizing secretary of EPCON Foxy, published quite a few papers and presented quite a few also. And she has done the PPH bundle work at Sevagram, which is a very, very important project. She has held office posts in Bhopal OB-GYN Society and has been the past vice president. So I welcome you to deliver your talk. Yes, Shabana, floor is yours. Yeah.
Thank you so much. And good evening, everyone. And at the outset, I'm very much privileged to be a part of this ICOG certificate course for medical disorder. And thank you so much to the organizing team for involving me as a speaker. My topic is intrahepatic cholestasis. And can I share my screen?
Yes, please.
Yeah. Just 1 second. Is it visible?
Yeah,
Yes,
it is.
Right. Okay. So intrahepatic cholestasis is my topic. Intrahepatic cholestasis of pregnancy. We all know that it is a hepatic disorder and it is characterized basically by pruritus and an elevation in the serum bile acid level. It usually present in late pregnancy. That is, most commonly it is present in 3rd trimester. So let's have a look at what actually the liver functions, what happened to the liver functions in pregnancy. And we see that serum ALT and AST level do not changes during pregnancy. It remains in the normal limit, and serum AST ALT values above the normal limit before labor, it considered to be pathological. Alkaline phosphatase slightly rises during 3rd trimester because of the placental isoenzyme. Total bilirubin little bit decreases in all the 3 trimester, and serum GGT activity usually remains normal during pregnancy. Most common cause of liver functional derangement in pregnancy are pregnancy-induced liver diseases. So this intrahepatic cholestasis is actually poorly understood. It is a diagnosis of exclusion, also known as cholestatic hepatosis. It is characterized by pruritus, elevated serum bile acids, and abnormal liver function test. When we see the incidence, it is estimated to be 0.3 to 15%, and estimate ranging from 0.3 to 0.5. In Indian Asian population, it's about 1.2 to 1.5%, also having various seasonal occurrences and various risk factors. Now let's have a look on the pruritus in pregnancy. This pruritus is very common symptom sometimes, but we have to see whether it is presenting with a rash or it is presenting without a rash. If it is presenting with a rash, then it is pruritic urticarial papules and plaques in pregnancy. It may be atopic eruptions of pregnancy, and it may be pemphigoid gestinosis. So the treatment is maybe a local topical steroids, or sometimes the skin biopsy is required in pemphigoid gestinosis. But when the pruritus is presenting with no rashes and there is an elevated bile acids, or sometimes transaminases also increases, then we are in a suspicion of cholestasis of pregnancy. So we see that how this incidence of pemphigoid and this pruritic urticarial papule is there. It is 0.6. These are all the group of disorder which are not very common but may be present in 3rd trimester, and they are not affecting fetus. But intrahepatic cholestasis, the itching is there, generalized itching is there, more on the palm and the sole, and the fetus is also affected. So these are the photographs which are showing pemphigoid gestinosis. It is late onset, mostly abdominal and periumbilical involvement, and it is visible in the form of vesicular or the bullae. Pruritic urticarial papules of pregnancy also occurs in the late 3rd trimester, and predominantly it is along the strias. Now we see various conditions associated with pruritus without rash. Because not only I told you that it is a diagnosis of occlusion, not only this intrahepatic cholestasis is present with pruritus without rage, but other diseases also present. So we have to exclude like chronic renal failure, sometimes hyperthyroidism, other liver diseases, maybe in the form of helminthosis, HIV, Hodgkin leukemia, non-Hodgkin's leukemia, various tumors, drugs like in the form of hydrochlorothiazide and multiple sclerosis, and various psychiatric problem also produces these type of rashes. Drugs that causes liver injury, I want to mention that there are various drugs which are causing liver injury, like in the form of paracetamol, methyl dopa, propylthiouracil, nevipripine, and progesterone, estrogen, first and second generation antipsychotic drugs. So these are all the general slides which are showing what are the causes which causes pruritus and what are the drugs which are causing liver injury. Now, when we see the guidelines, what the guidelines are telling us regarding the terminology of a pregnant woman with itching, it is gestational pruritus. Normally, we consider the upper limit of bile acid concentration in pregnancy is 18 micromole. And if it is 19 micromole, I mean less than 19, then it is considered to be gestational pruritus. When it is between 19, more than 19, then it is intrahepatic cholestasis, and the mild form of intrahepatic cholestasis presenting with itching and raised bile acid concentration between 19 to 39. Moderate intrahepatic cholestasis of pregnancy is between bile acid concentration between 40 to 99 micromole per liter, and the severe intrahepatic cholestasis is more than 100 micromole per liter, and it is one of the severe condition. So we see the etiology and we see it is all multifactorial because it is related to, it is a known theory that is related to estrogen, higher estrogen level in pregnancy. There is also altered expression of hepatobiliary transport proteins. There are multiple gene mutations which are now studied and explained also. Also, there is ethnic and familial clustering, and there are various environmental factors which are involved. So genetic susceptibilities, there are autosomal recessive progressive familial intrahepatic cholestasis involving gene ABC4, and altered genes are also involved in the form of NRI112 and NRI1H4, and environmental factors are also proven, like it is seasonal sometime in the winters, it is with the deficiency of vitamin D and selenium, multiparity is involved, multiple pregnancy is involved, ethnicity is involved, diabetes and hepatitis, other hepatitis, hepatic disorders may be involved along with the IHP. Personal and family history really plays a very important role. If the patient is presenting with a personal history, she may have a recurrence rate of almost 90%, advanced maternal age, and the patient with ART, and of course the hormonal factor like supplement of progesterone and estrogens. So these are the slides again showing that there is a familial clustering, involvement of hormones when it reaches to peak, and various proven theories are there that estrogen progesterone causing intrahepatic cholestasis because it is known to be more common in twin pregnancy, and it is associated with higher level of circulating estrogen than in a singleton pregnancy, and also in patient when we are giving early pregnancy after ovarian hyperstimulation. Again, there is a marked high level of estrogen and the ICP is there. ICP resolves following delivery of placenta, and which is one of the major source of production of hormones. And in the patient taking contraceptive pills, sometimes cholestasis occur, although the recent theories are showing that yes, patient of ICP also can be given oral contraceptive pills. One very important thing is there that hydroxyprogesterone caprioate, it is reported 8% incidence of pruritus in treated patient, and it is listed cholestatic jaundice of pregnancy and other liver tumors or liver disorder. This drug is contraindicated. So increased risk is known through the exogenous estrogen progesterone supplementation also. When we see the food, we see that low level of vitamin D and low level of selenium is really associated with ICP. Underlying liver disorder, various studies, various retrospective case control studies done, which are showing that these patients who are presenting with a pre-existing hepatobiliary diseases like hepatitis C, non-alcoholic liver cirrhosis, gallstone, they are having more chances of development of ICP. The risk factor, I am again repeating, it is multivital gestation, advanced maternal age, patient presenting with other liver disorders like chronic hepatitis, vitamin C. Personal history, 40 to 90% in the recurrence rate, and family history, 92% recurrence association is there. Now we come to the symptoms of this ICP, and a very important comment or quote is there that never ignore a itch in pregnancy. Never ignore a itch in pregnancy. When a patient is coming to you only with a symptom of itching, it is really, really important. So the main symptom is itching, pruritus. It can be everywhere, but oftenly noticeable on the hands and feet, and it is worsen at night. Severity of itch is not related to bile acid concentration. Sometimes it is low with a very high bile, or sometimes it is maybe milder. But some patients, they are also presenting with a right upper quadrant pain. They are presenting with a dark urine and pale stool. So as we all do that, to make a clinical diagnosis also, a good history taking and a good physical clinical examination is really, really important for concluding any diagnosis. In ICP also, it is considered to be a good history taking is really plays an important role. For evaluating these patients, we should assess onset of pruritus, extent, severity, aggravating factor, alleviating factors, timing, medical history, various drug association, various allergy history, family history is really important of any eczema, allergic rhinitis, any type of household contacts, any travel history, any sexual history, history of IV drug abuser, history of hepatitis, history of HIV. All these history are very important. And then also there are very important history, that is any history of ICP in the previous pregnancy. As I told you that the recurrence is almost 90%. Now, a good examination is really very important, in which we have to see there are scratch marks. The pruritus is more over the peripheries like palm and sole, but also on the abdomen. And we can see various scratch marks, various excoriation, various nodules secondary to scratching. And we can, jaundice is not always common, but it is present in 14 to 25% of the patient. Jaundice without pruritus is rare. And if it is there, we have to see for other investigation. Dark urine and jaundice are not commonly associated with ICP. And if it is there, then we have to rule out other hepatic diseases. So when we see the diagnosis, the symptoms as well as intrahepatic cholestasis, it is associated with abnormalities expected to be resolved in 1 to 2 weeks. We all know. So it is in the pregnancy very high in third trimester. And total serum bile acid level of more than 19 is often we are taking a cutoff of the from the guidelines, and also there's increase in the serum transaminases and aspirate aminotransferases. They can also sometimes to be elevated, and alkaline phosphatase, it is not very typical or diagnostic criteria of ICP. Only we are taking up bile acid concentration, but it is found to be elevated in 60% of the patient. We see all these symptoms, all these abnormalities are expected to be resolved in 1 to 2 weeks postpartum, but sometimes they persist up to 4 weeks. So to make a diagnosis, it is actually a diagnosis of exclusion, which is in the presence of maternal pruritus predominantly on the palm and sole, and there is an elevated of random bile acid. We are taking a random bile acid concentration of more than 19 micromole per liter. So these are the laboratory findings: elevated level of bile acids, elevated level of SGOT, SGPT, and sometimes alkaline phosphatase. The method we are using for the serum bile assay is total and fractionized assay of the bile acids in the form of by using mass spectrometry, liquid chromatography, which is giving the result in 4 to 14 days, and also the enzymatic method, which is giving results within 4 hours to 4 days. Now, what are the effects? How this intrahepatic cholestasis is affecting mother and fetus. Mother, we know this have to be managed with a consultant-led maternity unit. There is a sleep deprivation, decreased quality of life, because the main symptom is itching. Itching marks as there is steatorrhea is also there, that is malabsorption of fat-soluble vitamins. These patients, they suffer having a more chances of suffering with preeclampsia, GDM. And if they are presenting with these comorbidities, the risk of stillbirth is high when the patient presenting. Studies are not showing that it is actually associated with postpartum hemorrhage, but if deranged, I mean the severe variety of more than 100 micromole of the bile acids and raised level of SGOT, they suffer from postpartum hemorrhage as well. So the recommendation for the women of the ICP, consider repeating liver function test is after 1 week and then determining we can do it on the individual basis. Long-term complication, various studies are showing that there are high incidence of hepatobiliary diseases later in the life, hepatitis C, chronic hepatitis, hepatic fibrosis, cirrhosis, gallstone worsening, cholangitis. These are all commonly associated problems in the long-term complication. And the children born to ICP women, they were found to have more risk of developing high body mass index and dyslipidemia at the age of 16. When we see fetal effect, we see that the pathophysiology of stillbirth in ICP is poorly understood but has been hypothesized to be related to development of fetal arrhythmias or vasospasm of placental chorionic surface vessels induced by high level of bile acids. There is meconium Steinleicher, there is preterm births, there are respiratory distress syndrome, fetal distress, abnormal CTGs, and more operative delivery. So clinician should be aware that fetal ultrasound or CTG is not only the thing which we are predicting to preventing stillbirth, but recommendations are there that we have to advise patient to monitor fetal movements is really, really very important for the for prevention of stillborn. Another meta-analysis is showing that they see the 23 studies are compared to the perinatal outcome of the women with intrahepatic cholestasis, and they found that there is sudden uterine demise, meconium stent amniotic fluid, spontaneous preterm birth, iatrogenic preterm birth, and neonatal ICU admissions. Now, what are the risks of a stillborn? And it is totally dependent upon the bilirubin level. If it is more than 100, there are more chances for higher risk of a stillborn than the other milder and moderate form. We advise the woman if the patient is presenting with the risk factor of comorbidities such as gestational diabetes, preeclampsia, multifetal pregnancy, it appears to increase the risk of a stillborn. There are more chances for stillborn in these patients and also in the patient with the twin gestation as compared to single. So also the patient, they are presenting with moderate to severe ICP, they are presenting with higher chances of spontaneous iatrogenic preterm birth. There are higher chances of meconium stain amniotic fluid during labor and birth. And these babies, they really required more intensive neonatal care. So we come to the guidelines, and the guidelines are showing that in the mild ICP, the risk of a stillborn, the prevalence stillborn is only 0.13%. And if in the moderate 40 to 99 micromole, the chances of stillborn is 0.28%. In severe ICP, that is more than 100 micromole, the chance of stillborn is 3.44%. So as the bile acid level is increasing, the chance of stillborn and the morbidity, both maternal and fetal, is increasing. When we see this chart, it is just a comparison between various biological, hematological profile of various pregnancy-associated liver disorder in which hyperemesis we took because sometimes because of the dehydration and excessive vomiting, there is multi-organ effect. So, but it usually occurs in first trimester. So it may be in the DD, but it's usually in the first trimester. Then the preeclampsia help was really important because these patients, they are presenting with increased bile acid, increased bilirubin, and also they are presenting with increased uric acid and low platelet, which is not there in intrahepatic cholestasis because it is the only one which is in which the only bile acids is increasing. Sometimes the enzymes are increasing. In acute fatty liver, hypoglycemia is very much prominent, and they are presenting with a very high level of bilirubin. So these are all the charts which are showing differential diagnosis, that how we are going to diagnose.
Excuse me, Dr. Shabana, we have run out of time. Kindly conclude.
Okay. So these are all the differential diagnoses like acute fatty liver, and management is ursodeoxycholic acid, the main drug we are giving. It is given in 300 milligram thrice a day. Okay. It is well tolerated. Other drugs like antihistaminic, vitamin K, emollients, we can use rifampicin along with UCDA. We can use adenosyl methionine 1000 to 1500 milligram. We should avoid various antibiotic in these patients. This is the one very important thing, that these patients, they should be advised to monitor fetal movement, which I've already mentioned, and the timing of delivery depending upon the bilirubin level. If it is more than 100, then we have to deliver it 34 to 36 weeks, and we have to give corticosteroid as well. So these are all the timing. Ma'am, we are not having 2-3 minutes. So it's really the time up.
Exceeded more than 4 minutes.
Okay, ma'am. Okay. So I'm just showing one chart that if it is more than 100, if it is mild to moderate, we deliver it 37 to 38. If it is more than 100, we have to deliver it 34 to 36 weeks, and with a coverage of steroids. So this is the optimal time. Maternal outcome is good usually in patient, except when if it is persistent derangement of the liver function test, we have to search for the other liver disorders as well. So follow-up is up to 4 to 6 weeks in the postpartum phase. Postpartum counseling and follow-up is really important. What contraceptive we can give? We choose non-hormonal. Basically, we have to choose non-hormonal, but in the new guideline, it is showing that hormonal can also be given with caution. And the last message of mine is do not ignore the EACH. Intense EACH is not normal. It could be ICP. Intervention, treatment, and early delivery can make all the differences. This month is actually intrahepatic cholestasis of pregnancy awareness month. So let's raise awareness. Don't ignore the EACH. Stillborn is one of the risk factors. Thank you so much.
Chairpersons, to kindly conclude the talk. Any comments? Shobha Gudi, ma'am? Fesi sir can comment. Sir, you're muted.
We have got 2 more talks now, and then we will conclude.
Yes. Okay, sir. So, Dr. Shobha Gudi, are you there, madam? Dr. Durga, ma'am has joined. Shanta Durga, ma'am has joined.
I think I saw her.
Yes, ma'am.
Yeah, I was not able to unmute, Monica. That is why.
Sorry, madam.
Yeah.
Some glitch from the office, I think.
Yes. So it was a very, very informative talk, no doubt. But I only wish that speakers would kind of concise themselves and adhere to the time. So hopefully, that will happen in future. Now, the thing is, yes, it is the awareness month for ICP, and it was very good that today we had this particular discussion. And this complication is not uncommon, because many often obstetricians feel that it is an uncommon thing, but it's not uncommon, and it has its own toll to be reckoned with. So I think we have to be very, very aware, and thanks to the speaker for highlighting that. Thank you. Please go on to the next speaker. Yeah.
So I would request Dr. Shanta Durge, madam, to kindly introduce the next speaker of session 2, Dr. Chandrika Anand.
Good evening to all, and I am really thankful to the organizing team for including me in this certificate course of ICOG, and Dr. Chandrika Anand, who is the Chief Consultant at Fortis Hospital, Nagarbavi, Bangalore, top 10 gynecologists South India, according to Outlook and India Today peer survey. South Zone Coordinator of Endocrine Committee, FOXY. Managing Committee Member, PCOS Society of India. 8 gold medals in MBBS. That is too much. Huh? Areas of interest. Yeah. PCOS, high-risk pregnancy, research. ICOG faculty for PCOS and committee member and contributor for FOXY GCPR on PCOS 2023. First prize in free paper presentation or original research heavy metals in PCOS at ASAFOG conference 2023. Co-editor for FOXY Focus, Harmony of Hormones 2023, and authored many articles and textbook chapters. So we are lucky to have such a speaker here today. Over.
Thank you, madam. Thank you so much. I think I'm sharing my screen. Is it visible, madam?
Yes, madam.
It's visible.
Thank you for the kind introduction, and thanks ICOG for giving me and Dr. Charmila for giving me this wonderful opportunity. So I'm just going to talk about psychiatric disease and pregnancy, a little vague and dark subject. And most of us either we are too busy or preoccupied, or maybe we just miss the symptoms or the red signals what the patients are showing. So it is indeed very insightful to know about the psychiatric diseases in pregnancy. I will be brief, madam, this 15 minutes. Yeah. Okay, so what is the prevalence of this mental health psychiatric disorders in the world? Particularly in men and women, we can see that anxiety disorders, panic, phobia, and obsessive compulsive disorder and major depression is more common in women. Almost 20 to 40% of women all over the world could be suffering from one or the other type of psychiatric disorder. And then in obstetric and gynecology practices routinely including the menopause and that is gynec patients, obstetric patients, almost around 20 to 48% of women could be suffering from one or the other type of a psychiatric disorder. Major depression is the commonest one, that is 22%, followed by anxiety. And what is the prevalence of psychiatric disorder? Particularly in pregnancy, is 1 in 5 mothers. Can you believe it? 1 in 5 mothers, that is 20% of women in pregnancy, could be suffering from a mental health condition. That is all this most common being depression and anxiety. And in the West, where PPH and anemia is not a challenge, in the US and UK, maternal mental health condition is the most common complication of pregnancy and childbirth. And also the maternal, it contributes a high percentage for maternal mortality in the developed countries, because here in India we are still grappling with anemia and PPH, whereas the in the West, maternal mental health conditions and suicides contribute a very major component. Now, what we need to notice is that the reproductive years are the most likely times for women to have any type of a prevalent psychiatric illness. And pregnancy is a significant risk factor for developing a new mental health condition. So now there is a group of women who already have a history of depression or anxiety or a psychosis or a schizophrenia. And now there is a new set of apparently healthy pregnant women who enter the pregnancy healthy, but then they could develop a new mental health condition. Now, who are these women? Like who should we be worried about when we are seeing them every month? See, if they already give a history, that is fine. If they do not give a history of psychiatric disorder, now which are these women we need to be little concerned about? Are these unwanted pregnancies, unintended pregnancies, recurrent miscarriages, pregnant women who have taken a lot of fertility treatment, the perception of a traumatic or unpleasant birth experience previously, previous vaginal delivery, they are very traumatic, they've had a complication, women with their babies in the NICU, women with multiple medical complications, as all of us have heard throughout these 3 days, and unexpected cesarean deliveries, all these women are prone to develop a new mental health condition during pregnancy. Now, these are the women we should be looking out for mental health conditions. And also, these women who already have a mental problem, they stop all their treatment during pregnancy because they're scared that the baby will get affected. Now, these untreated mental illness among pregnant women will increase their risk for high-risk behaviors like promiscuity, smoking, drinking, drug abuse, and also inadequate lifestyle. They don't sleep well, they don't eat well, and also grave complications like suicide and sudden infant death syndrome. So this is the data from the US and the US states. They found out that that is a leading cause or leading contributor, like how anemia contributes in India. Leading contributor is for maternal mortality is mental health conditions. As I was just talking about it, which are the women who are at high risk for maternal mental health condition and whom we should be worried about is a woman with already a history of anxiety, depression, psychosis, or a family history of mental health, mental illness. And all these, that is baby, I just enumerated women who lack social support, intimate partner violence, women who have experienced birth trauma, previous sexual trauma, all those women are more prone. Now, what do they make them more prone during pregnancy? Because there could be a combination of biological reasons, that is, hormones during pregnancy, Psychological reasons, because some women struggle with the change in role of relationship and responsibilities. And social reasons, that is, the childbearing years are often very stressful to women, in particularly women who are working women and working at home, and financial stress. Now, what are the clinical cues? Suppose we are sitting in the OPD and, do we hear these things? Do we just brush it off, or should we be little concerned and then screen them for mental health? Now, these are some of the cues, clinical cues the patients keep talking about, that how they are exhausted, they can't sleep, they want to run away, and I'm not bonding with my baby. Having a pregnancy was my mistake. These are all some of the inputs they talk to us, and then we should be very careful in noticing that and referring to a psychiatrist or a therapy. Now, what is the timing and onset of anxiety and depression? 27% of women, they enter the pregnancy with anxiety or depression. 33% develop during the pregnancy. Almost up to 40% develop after the delivery. Now, what are the barriers to accessing healthcare or mental health help by these women? Because we have got such a social and a cultural barrier that they feel ashamed and guilt, and they don't have the access to healthcare, and social biases, logistical challenges. Women of low income and rural areas are more likely to experience, but unfortunately, they are less likely to be able to access the healthcare. Now, how do we approach a woman with a mental health disorder or psychiatric problem? So, along with the history taking, we need to be asking about their main symptoms, history of their past pregnancies and their outcomes, traumatic pregnancies, obstetric complication, perinatal mortality, and recurrent miscarriages. All those details we need to check. And then current pregnancy details, including the psychosocial context. And physical examination, sometimes they can mimic a actual problem like a hypertension, anemia, jaundice, thyroid. All these we need to rule out, and simple blood investigations to rule out the that is the actual organic problem, and then reference to the psychiatrist for further evaluation. Now, what is the role of OBGYN? So we need to, once there is a woman, suppose there is a woman with a depression history, so we need to explain the benefits, risk and harmful effects of the psychiatric problems during pregnancy on mother and the fetus. And we need to insist that they take treatment, because without treatment, they can have high risk behavior. And then what is the medications they are taking? What are the bad effects it can have on the baby? Because a lot of medicines can directly associate with fetal defects. Okay, so we need to be mindful about all this. And principles of pharmacotherapy, most often the psychiatrists will deal with it, that they minimize the dosage, single drug dosage, and compliance should be ensured. Self-care, this we can counsel them for a self-care, that is, we ask them to take good sleep and nutrition and exercise, expose them for light, ask them to go for a walk and do some light exercises and yoga, and time for oneself and sharing and support groups. All these things we can guide the patient to do. Coming to a few of the mental health conditions which we commonly encounter, I know it is a very exhaustive and a very big topic, so I'm just going to briefly share some thoughts about what we can do. So depression in pregnancy and postpartum is the commonest mental health condition in pregnant women. Almost 4% in first trimester, 12% in second and third trimester, 40% occur during postpartum period. Now, how do we know? They have this change in appetite and sleep, energy, motivation, negative thinking, including guilt and hopelessness and worthlessness, irritable, angry, lack of interest in the baby. They refuse to feed the baby, intrusive and scaring thoughts, and self-harm or harming the baby. All these thoughts indirectly they will talk to us. So we need to screen for depression, and then this depression can cause low birth weight and increased risk of preterm delivery, maternal preeclampsia. So what are the guidelines? So please, once you screen and the patient is having a depression, please take a psychiatric reference you send, and then watch out for more, that make sure that they're taking the tablets. And mild cases where psychotherapy or counseling is enough. Moderate to severe, they may need medication. And these are some of the commonest drugs which the psychiatrists use. That is SSRI, SNRI, and TCA. They are relatively safe, but then there are some of them have got a mild increase in cardiac defect, and there is this neonatal adaptation syndrome, and sometimes suddenly stopping the drug can cause withdrawal syndrome. So all these we should be mindful, and we should be counseling them. Postpartum depression, I'm sure all of us gynecologists have seen a lot of women with postpartum depression. And unfortunately, two of my patients have committed suicide because of this. So we make it a point to give counsel them regarding these symptoms, that is a negative symptom during the postpartum, and then ask the relatives to bring to us whenever they talk about these things. So 25 to 80% of women have some kind of a postpartum blues. It is a fleeting thoughts of low self-esteem and emotional ability. For them, reassurance and exercise support is enough. Whereas actual depression, there is a Edinburgh scale to measure this. So please download from the internet and then give to all your patients, delivered patients who you feel that they could be having a postpartum depression. So once you diagnose, please refer to the psychiatrist, because they have got a very bad effect on the baby. There can be a sudden infant death syndrome, and these babies could be a high risk for anxiety also. And the most important is the woman committing suicide. The suicide, as I told you in the West, it is very, very common. So it is a very important risk factor. Even suicidal thoughts also we should be mindful. Electroconvulsive therapy or the ECT or the shock therapy also can be given in very severe depression or mania and psychosis. It is supposed to be safe during pregnancy. Anxiety in pregnancy is the second commonest problem what we notice during pregnancy. 8 to 15%, they feel easily stressed and worried, and all the time they're thinking negative, all these problems will happen to me, and they develop panic attack, they start sweating, they faint, and they have this trembling and all those things. So we need to educate them about the symptoms. If they are persisting symptoms, we need to refer to the psychiatrist, because anxiety can cause preterm labor, low birth weight, and on the mother it can cause preeclampsia and increased rate of cesarean section. Now there is something called tocophobia, where the women are worried about pain during normal delivery, so they refuse normal delivery. So we need to be mindful of that and then refer them to counseling and treatment if necessary. Bipolar disorder is maniac depressive psychosis. So 3% of women have this, and then they are very high sometimes, they are very low sometimes. Again, these are rare 3%, but again we have to be mindful about their symptoms, and then we can refer to the psychiatrist and go for treatment. And the medications is a lithium. This is a very, very important tablet, lithium, but then it is known to cause cardiac defects. 10 to 20 times high risk is there. So women who are on lithium and valproic acid or carbamazepine, which are known to cause neurotubal defects, we need to do a level 2 ultrasound, fetal echocardiogram, because sometimes they become inevitable to take it. So we need to do a good surveillance of the baby. Schizophrenia, we know that schizophrenia, they have these negative thoughts and delusions and hallucinations. Again, in pregnancy, there can be non-compliance. They may not take this medication. They may not take any tablet. They may not come to meet the doctor and all that. So these women, again, they are more prone for preeclampsia, thromboembolic disease, and low birth weight and preterm delivery. Most of the antipsychotics what we use for schizophrenia are safe in pregnancy. So sometimes if they are too much agitating or very psychotic, we need to admit them. ECT also need to be given. So these are some of the medications given, and the psychiatrist will ensure that the patient is compliant. Substance use disorder, generally not so common in India. That is, these women take to using tobacco, alcohol, and recreational drugs. These are briefly talking about post-traumatic stress disorder and eating disorders. Again, they are common. We need to be very, very cautious when they are talking, when they are dropping hints. We need to make sure that we screen them. Psychosis is a medical emergency, 1 to 2 women per 1,000 births. And then these women suddenly they become very, very violent, and they are delusional, and they may commit suicide. So we need to admit them, give them treatment under multi-specialty care and hospitalization, sedation, clozapam. Sometimes even ECT also has to be given. Now this is summarizing the whole talk. So what is the condition of prevalence in pregnancy? What are the bad effects on the mother? What are the bad effects on the baby? And what are the medication used? Here, apart from as such, the condition can have a bad effect on the mother and the baby. Even the medications also can have a bad effect on the baby. So we need to weigh the risk and benefit of ratio, whether the medicine is more beneficial to the mother, then we need to explain the risk to the potential risk to the baby. We need to make sure that, see, once we diagnose a psychiatric disorder and refer to the psychiatrist and they give some medication, it becomes our duty in each antenatal checkup to make sure that they take the tablets, they follow a good lifestyle, and the antepartum surveillance we need to do. fetal echocardiogram we need to do, anomaly scans we need to do, make sure that prevention of preterm labor, birth weight, we need to do growth scans, and then make sure that they have a very supported delivery, and then even postpartum, we need to watch out for any postpartum complications or depression. So this is the algorithm, what is the role of the gynecologist. So we need to do all this. It's just now what I told, ensure lifestyle, compliance and reference, and make sure the pregnancy journey is safe for the woman with a psychiatric disorder. So I think I finished right in time.
Dot on time, madam. So concluding remarks by chairpersons, please.
Ma'am, you have given an excellent talk on psychiatric diseases during pregnancy. And we should all appreciate your talk. And the prevalence is more, 20 to 48%. But, hello, can you hear me? But in India, we are lucky that we get the family support, and so the prevalence may be less compared to the Western countries. And because of the lack of support, the psychiatric problems and these symptoms, they mimic anything. Depression is the most commonest one. And antipsychotic drugs, when we use to the patient, the benefit versus the risk should be weighed, and the fetal surveillance as well as the maternal surveillance both are very essential. What we took the message from the madam's speech, and it was really, really excellent. And we all will be benefited with her talk. Thank you. Thank you, Dr. Chandran. Thank you.
Thank you so much.
Shanta ma'am, I would request you to introduce our last speaker of session 2, Dr. Ashish Kumar Mukhopadhyay.
Good.
Sir will be taking the talk on APLA, Antiphospholipid Antibody Syndrome.
Good. Dr. Ashish Kumar Mukhopadhyay, whom I know since many, many years. He has organized one Kolkata conference. Since then, we are the friends. And he is the really very good speaker. And now he is the principal and professor and unit chief at CSS College of Obstetric and Gynec and Child Health, Kolkata. Vice President Foxy 2016 to 17, Governing Council Member ICOG 2021 to 22. Sorry.
That will be fine, madam.
President, the Bengal OBG Society, ex-chairperson, Medical Education Committee Foxy, and Scientific Chair AICOG 2022, WHO Fellow, Maternal Health. So, sir, it is a lot there to read about the CV, and you can proceed now.
I know. Thank you very much, Dr. Shanta Durge. And my respectful regards to not only the chairpersons of the session, but also our president, Dr. Smita Tendulwadkar, our ICOG chairman, Dr. Parag Biniwale, Dr. Sheila Mane, Dr. Suvarna Khadilkar, Dr. Ashok Kumar, and Dr. Sarita, and also the coordinators and the conveners of this program who have done a wonderful job. I'm very happy that ICOG has taken up these topics, wonderful topics they have included in medical disorder in pregnancy, which just shows their farsightedness and appropriateness in inclusion in the scientific program. So with that, I hope that I'm visible and I am audible. And then I'll try to share my screen now.
Yes, you are audible.
Can you see my screen now?
Yes, sir.
Okay. So this fascinating condition called APS or APLA or APLS, whatever way you call it, antiphospholipid antibody syndrome or antiphospholipid syndrome, is a very, very, very fascinating topic in the sense that a lot of things are not, elucidated till now. And I must say that in the last 2 decades, a lot of things have unfolded also in this antiphospholipid antibody syndrome. It is a systemic autoimmune disease. I'll define it right now. It is also known as the Hughes syndrome. And the organs involved that are, apart from thrombosis, there will be neurological manifestations, hematological, cardiovascular, and renal manifestations, the chief manifestations. But obstetric complications are the hallmark of the disease. So that's very, very important from an obstetric point of view. To define it properly, it's a systemic autoimmune disease characterized by the thrombosis and or obstetrical events, mind the word and or, that occur in an individual with persistent antiphospholipid antibodies. So these are the antibodies when your own tissues become foreign to yourself. These antibodies are formed inside the body. And there are many such examples, many such conditions where it can happen. But antiphospholipid syndrome is supposed to be the very unique one. There are many types and classification of APS. The classical one is a thrombotic presentation. Non-thrombotic presentation can be in pregnancy also without any thrombosis, history of thrombosis. It can be an asymptomatic carrier also, or it may involve the multi-organs. That is called catastrophic. It can be primary, which usually we call it when there is no SLE associated with it, or a secondary with SLE or any other disorder. It can be drug-induced, it can be infection-induced. Now, there are so many variants of APS that you need to go into the seeing the prevalence of this condition according to different conditions. Asymptomatic, you see in the population 1 to 5%. So that's not very common, I must say. Venous thrombosis occurs in 22% of cases. We're not talking about obstetric conditions now. We are talking about APLA in general. Then recurrence of venous thrombosis is also very common, which is kept separately just to emphasize the importance that once a venous thrombosis happens, it tends to recur 25% of cases, and that there's a need for lifelong therapy in these patients. Stroke happens in 13% of cases, and myocardial infarction happens in 11% of cases. So modest amount of prevalence. Deep vein thrombosis is perhaps by far the commonest presentation of this condition. It happens in roughly 40% of cases. But the fetal losses, early and late, they occupy a very important position, 35.4% early fetal loss and 16.9% late fetal loss. And stillbirth happens in 15% of cases. It's a very important cause of recurrent spontaneous abortion or recurrent early pregnancy loss, REPL, so-called, 5 to 15%. IUGR or FGR now called, it happens in 10 to 15% of cases. Preterm labor happens in 10% of cases, and preeclampsia, eclampsia happens in roughly 10% of cases. Fetal loss is more common than the abortions in antepartum and antiphospholipid antibody syndrome. Lupus anticoagulant, will come to these later on in a bit elaborate form. And anticardiolipin antibody IgG has strong association with thrombosis and pregnancy loss before 24 weeks. ACL IgG is more important than IgM for obstetrical events. This is one condition where the IgG plays more important role than IgM. 80% risk of fetal loss if high ACL IgG and previous fetal loss is there. So previous obstetric fetal loss history is very, very important. That happens in most of the cases. Now, what is the etiology? It's actually, as I said, your own body becomes foreign to yourself. The passive transfer of maternal antigens happen, which mediate the autoimmune disorder in the fetus. The genetic association is there, has been claimed to be associated with HLA-DR4 and HLA-DR7. So there is a familial occurrence. And infections, there are many causative agents like parvovirus, B19, cytomegalovirus, the varicella, HIV, even H. pylori, they cause this infection. And drugs, phenothiazines and chlorpromazine are only a few of the rest of the drugs. Now, this infection, why does it happen? Why does it lead to antiphospholipid syndrome? Let us see. There is a molecular similarity between the beta-2-glycoprotein and the microorganisms. And the proteins of the organisms, they cause polyclonal activation of T cells or B cells of the lymphocytes. And there is modulation of the release of the cytokines. These cytokines actually causes all the damages. Now, these APL antibodies like ACL, ALA, and anti-beta-2-glycoprotein 1, antibodies to prothrombin and annexin V, they cause activation of the endothelial cells, monocytes, and platelets. three areas where they play randomly havoc: expression of the adhesions on the adhesions on the endothelial cells, and there is upregulation of the tissue factor and complement activation. So the whole cascade is now opened, and thereby it produces cell-mediated immunity and humoral immunity. Now, essentially, this is an enhanced procoagulant activity. That means coagulation is promoted. There is increased expression and activation of the tissue factor, expression of the adenosine molecule rather, impaired fibrinolysis, and decreased prostacyclin production. So everywhere, the body now promotes the vasoconstrictor substances and the all the cytokines which cause damage to the endothelial cells. That preponderance is there. Two special cells who are affected in the cell-mediated events. One is the monocyte, another is the platelets. And we all know that monocytes causes expression of the tissue factor and increased oxidative stress or reactive oxidative species. And platelets causes enhanced aggravation or activation and thromboxane A2 production in preference to prostacyclin production. So this is roughly the schematic diagram of how the pathogenesis happens, and it ultimately leads to the antiphospholipid antibody affecting all these organs and cells and platelets and monocytes and endothelial cells. And the effect is largely this. At the end of the vessel, you can see a clot generated, and this clot is generated because of the complex interaction between these causative agents and the body's own so-called defense mechanism, which leads to the formation of the clot. So that is the basic pathogenesis of the APLA. In pregnancy, there are three things basically. One is the thrombosis, which may be an isolated event, which may or may not be associated with pregnancy losses, but it has its own effects on the trophoblast, and also it has got immune activation. We'll see how. Let us talk about thrombosis. Increased thromboxane A2 activity I've already mentioned, and decreased prostacyclin activity. So this, as I said, the system in the body is now more prone towards constrictive agents like thromboxane A2 in preference over the prostacyclin activity or dilatation events. And there is disrupted interaction between the beta-2 glycoprotein and surface of the trophoblastic cell membrane. This is very, very, very important. And displacement of the annexin V from the annexin 5 from the trophoblastic surface. So these are the generative mechanisms by which the thrombosis develops. How is the immune system is activated? Promotes immune and complement activation of the feto-maternal interface. This is also important because the feto-maternal interface, which were apparently foreign to all these things happening inside the body, now gets affected. So the immune and complement activation of the feto-maternal interface now starts. It binds trophoblastic cell membrane and stimulates the neutrophil infiltration and activates T1 necrotic factor and tissue factor linked to fetal loss. So that is ultimately leading to the fetal loss. So this is the genesis of the fetal loss that actually starts from the feto-maternal interface and all those complex cellular reaction that is happen throughout the body. Now you see that there has been a lot of progress, as I said, in the last 20 years, 2 decades, about the diagnosis classification of APS. Initially, 1999, Wilson published Sapporo criteria, which was followed rigorously till 2006, when it was modified a bit, which is called the Sydney classification. And then came these new concepts of pathogenesis about the inflammatory reactions, vascular damage in the endothelium, and the resultant cytokines production. And also the treatment advanced from that point onwards, because we knew which drug works where. In short, if you want to discuss what is Sapporo and what is Sydney classification, but before that, let us see what is there in the revised Sapporo antiphospholipid syndrome classification. Criteria are very, very important. And this has been present in at least one of the clinical criteria and one of the laboratory criteria that must be there to fulfill the diagnostic criteria of APLS. So clinical criteria are, first of all, vascular thrombosis. Where can it happen? It can happen in arterial wall, it can happen in venous, or even small vessel thrombosis in any tissue or organ. Thrombosis must be confirmed by objective validated criteria, mostly by ultrasound, or maybe by histopathology. For histopathology confirmation, thrombosis should be present without significant evidence of inflammation of the vessel wall. That means the vessel as such, per se, it was not diseased. You have to show that. That's a difficult task. So we want to resort to imaging for showing this vascular thrombosis. And nowadays, imaging has progressed tremendously, and we can see even small vascular thrombosis very, very vividly. Now, what are the pregnancy morbidity conditions which are essential for this original and the revised Sapporo classification? You see, if you have to have an unexplained death of a morphologically normal fetus at or beyond 10th week of gestation, after 10th week of gestation, you need to have one fetal loss. With a normal fetal morphology, which is documented by ultrasound or by direct examination of the fetus. Sometimes we get to see examine the fetus. Secondly, one or more preterm births of a morphologically normal neonate before the 34th week of gestation. Now, this morphologically normal neonate, why should it go into preterm labor? There are reasons behind this, and the reasons should be either eclampsia, preeclampsia, or a recognized features of placental insufficiency. We'll define placental insufficiency also later. But if you have to have unexplained consecutive spontaneous abortions before the 10th week of gestation, after the 10th week, one is okay. But before the 10th week of gestation, without maternal or hormonal abnormalities and paternal or maternal chromosomal causes, you need to have 3 or more spontaneous abortions. So that is a very important thing. So these are the clinical criteria. One is vascular thrombosis, and secondly, the pregnancy algorithm that I have just described. Then lab criteria, lupus anticoagulant present in plasma on 2 or more occasions at least 12 weeks apart. You have to see whether in practical reality we do it or not. That's a different story. Anticardiolipin antibody of IgG and IgM and or IgM isotype in serum or plasma present in medium or high titer. That means more than 40 GPL or more than 99th percentile on 2 or more occasions, obviously, at least 12 weeks apart. So whatever antibody presentation you see, you have to see it twice, at least 12 weeks apart. And then anti-beta-2 glycoprotein, same antibody of IgG and IgM isotype in serum or plasma in titer more than 99th percentile. And it is measured by the standardized ELISA. No other technique has been described. So standardized ELISA has to be there. So this is at least one clinical criteria, say vascular thrombosis or say pregnancy events must be there, and one lab criteria must be there to define the syndrome, and that is the revised Sapporo classification. It was originally there in the Sapporo classification original also, but then now it has been quantified, and now the diagnosis have been much more clear. So here's the difference between the Sapporo classification and the Sydney classification. 2006, if you see, then the Sapporo Sydney classification is actually the specific criteria or thresholds used. It is used in clinical practice to help diagnose APS and inform treatment decisions. Actually, it's a refinement and expansion of the original Sapporo classification. So nowadays, we use the Sydney classification or revised Sapporo classification from 2006 onwards. Okay, now, when describing the APS, you should remember that classification of APS should be avoided if less than 12 weeks or more than 5 years separate. So 2 incidents, if they are 12 weeks, more than 12 weeks or more than 5 years apart, then you cannot depend on that findings, and you have to redefine itself. And there are some factors which will cause thrombosis by its own merit, and there are some risk factors. So they are called the coexisting inherited or acquired factors for thrombosis. They should not be confused with APS. For instance, age more than 55 in men and more than 65 in women. Comorbidities like the hypertension, diabetes mellitus, elevated LDL or low LDL, cigarette smoking, family history of premature cardiovascular disease, BMI of more than 30 kg per square meter, microalbuminuria, inherited thrombophilias, oral contraceptive pills, nephrotic syndrome, malignancy, immobilization, and surgery. It is not that every time they will be confused with APS, but they will cause thrombosis, which is very akin to the thrombosis caused by the APLA. So you need to differentiate between these two. A thrombotic episode in the past could be considered as a clinical criteria, provided that thrombosis is proved by appropriate diagnostic means, that means ultrasound. Superficial venous thrombosis is not included in the clinical criteria. Generally accepted features of placental insufficiency. Here I want to define the placental insufficiency, very important. Number 1, abnormal or non-reassuring fetal surveillance test like a non-reactive non-stress test, NST, suggestive of fetal hypoxemia. Abnormal Doppler flow velocimetry, you all know the things, that the absent end-diastolic flow in the umbilical artery, which is the commonest artery for fetal surveillance. Then oligohydramnios, like an amniotic fluid index of less than 5, a postnatal birth weight less than the 10th percentile for the gestational age. These are all the diagnostic points for placental insufficiency. Okay, so I think that we need to define placental insufficiency properly in these conditions.
Dr. Ashish, your time is over, but we'll give you some more time to conclude, 2 minutes
Yeah,
more.
yeah, just 5 minutes more. Okay. Okay, I will just go quickly, which are important, these clinical criteria, like vascular thrombosis, as I said, 1 or more episodes of arterial venous or small vessel thrombosis. It must be confirmed by imaging. There are some scores. There are many scores. I will just mention one score here. That is the global APS score, or GAPSS, in which antiphospholipid antibody, anti-cardiolipin, anti-beta-2 glycoprotein, lupus anticoagulant, they have their individual values. You can see, and these values are add up in the end to produce the score. And the cardiovascular risk factors like hyperlipidemia and arterial hypertension. So this score, which is published in 2013, is still used today, and it is significant if the score is more than 10. Higher values of thrombosis than pregnancy events, and there are high risk of vascular events also. Now come to the management quickly. Most important is pre-pregnancy counseling to me, because I like this topic very much. Then there should be a team approach, decide the aims of management. We should have focused antenatal care, and we can make them understand that successful outcome is available in 70% of cases. Now, preconception counseling, which is very, very important. I think I'll go through quickly. Assessment of past obstetric and medical history. You find out the risk factors. Associated SLE, you must exclude there first. Postpone pregnancy if thrombosis in last 6 months or active SLE. Correction of obesity, diabetes mellitus, hypertension is very, very important. Discuss the risk of obstetric events and thrombosis. Start low-dose aspirin. Switch over to heparin from warfarin in pregnancy, when we're having warfarin before pregnancy. And if it is a long-term heparin, then you have to go for the biomedical, bone density measurement. These are the aims of the management. All of us know the drugs are mainly 3: heparin, aspirin, hydroxychloroquine. I'll discuss quickly. Heparin, we know it's antithrombotic, very potent antithrombotic agent, prevents binding of APL to trophoblast, promotes trophoblast invasion, inhibits tissue factor. Low-dose aspirin is extremely helpful because it inhibits thromboxane A2 and takes the body circulation more towards the dilated side. What is the role of hydroxychloroquine? We have been using this since the COVID days. It prevents or inhibits platelet aggregation and reversal of the binding of antiphospholipid beta-2 glycoprotein complexes to the phospholipid bilayers. Restoration of the annexin D is possible by hydroxychloroquine, and protection against the thrombosis in SLE with or without APS. Dose, usually 1 milligram per kilogram body weight subcutaneously. OD if prophylactic and BD if therapeutic. Aspirin is, according to 2 colleges, a different 75 milligram is sponsored by British school, and 81 milligram sponsored by the American school. Now let us take 2 or 3 very small cases, which are very, very important vexing questions. Not cases, case-like conditions. Now suppose there is a pregnancy with APS.
Dr. Ashish, we have to have a panel discussion also, and we have to finish by 7. So I think we can do away with cases. Give the takeaway points, please.
Yeah. Okay, I'll go to the takeaway points. Okay. What if the pregnant woman with APL does not fulfill the APS criteria? Then there is LDA and LMWH as a limited scope here. Asymptomatic APS, seeking for lifelong therapy. LDA is possible, only close watch, and there is a scope of hydroxychloroquine here. I think I will skip these slides because there is no more time now. And prophylactic and therapeutic LMWH, all of you know, heparin usage, when to stop. Therapeutic heparin, that is 24 hours before elective LSCS, prophylactic heparin 12 hours before. And if you have the patient to onset of labor, stop immediately. So takeaway messages are, there have been commendable progress in the understanding of APS, the etiopathogenesis and the etiology and the outcome, 70% success rate, significant progress on learning pathogenesis and diagnosis. Heparin is safe during pregnancy, and warfarin is safe during breastfeeding. So you can revert to warfarin after the pregnancy is over, delivery is there. And low molecular heparin is nowadays more cost effective and requires less intense monitoring. So nowadays we prefer over unfractionated heparin. Thank you very much for your patient hearing.
Thank you very much, sir. Would the chairpersons like to conclude session 2 before we move on to panel discussion? Shanta ma'am and
Monica, I think we should move over to panel because we have to finish by 7, you know.
Right, ma'am.
And
Right, ma'am.
Dr. Ashish, please, if there are any questions in the chat box, because there would be, please
Okay.
answer.
Okay, Achala, my request is if Ashish is there, Ashish, you be there as an expert for our panel, because most of the things which slides, because those are included in our panel also the same case scenarios. Okay.
Okay, that will be a pleasure. Thank you, Sheila.
Yeah. Yeah.
So moving on to session 3, I invite our moderators for the session, Dr. Sheila Mane Madam and Dr. M. Krishna Kumari, who are the moderators. The topic of the panel is venous thrombosis in pregnancy. And can I have CVs?
Monica, don't waste time, please. We can
Yes,
just tell the names. No, just go ahead. Okay.
Yeah, Professor Sheila Mane.
No, that's all. That's all.
Yes,
Go
yes.
ahead. Go ahead. Yeah.
Dr. M. Krishna Kumari. She is
Yeah.
No, it's
also
okay,
moderator.
fine, Dr.
And
Monica,
I
go
would
ahead.
just like to name the panelists, madam, so that you
Yeah.
can come to know who
Yeah.
are there. Dr. Upma Saxena is there.
Yes.
Dr. Priya Kanappan.
Yes, madam.
Dr. Aruna Suman.
Yes.
Yes.
Dr. Rekha Rajendra Kumar.
Yes, Dr. Monica.
And Dr. Lavanya.
Yes, ma'am.
A warm welcome to all on behalf of ICOG. Thank you.
Thank you very much, Dr. Monica.
Thank you. We still have 363 people attending this panel. I think, Krishna, will you share the PPT?
Okay. You want me to?
Sheila, I would request you to be fast, you know.
Yeah, don't worry. Yeah. We will see to it that the thrombus is dissolved.
Hey, have you given me the
No, you
screen,
present whatever you have. Go ahead, Krishna.
No, that's fine. I'm asking if Dr. Monica has made me
Co-host.
co-host.
Madam, the ICOG office is doing. Nilima, please see.
Ma'am, she's already a co-host, ma'am.
Madam, you are co-host.
Okay, because
you're not able to share the slides.
1 second. Let me just check. Where is my Zoom gone?
Then discuss on my slides.
So then there will be only one topic.
No, she will.
Possible.
Yeah. Right. Can you see my screen?
Yes. Yeah, we can see your screen.
Okay, fine.
You can do the slideshow. Yeah.
Yeah. I'll do it.
Ashish can answer the questions in chat box.
Okay, let me see.
So I think this is the title. Thank God it is venous thrombosis and not thromboembolism. Otherwise, we would have had to speak even about the embolism and other cases. So over to you, Dr. Sheila, for the introduction.
Yeah, fine. So can we have the next slide? Krishna, can I have the next slide, please? Yeah.
Not full screen yet.
It is on the full screen.
No, it's not full screen.
It's not in the slideshow mode, madam.
It is. It's a play because mine is a.
Okay. I think we are able to see. Okay, we'll proceed.
It's quite visible.
Yeah, it's visible, no? Yeah. So all 5 of you, I would like to know, do you think there is a need for thromboprophylaxis in pregnancy? We can go to next slide.
Yes.
Yeah, Rekha?
Yes, there is.
If there is a need for thromboprophylaxis in pregnancy.
Madam, it depends upon the, it is because though pregnancy itself is a high risk factor, I don't think that all the cases need thromboprophylaxis. It depends upon so many factors of the pregnancy that will decide whether she needs thromboprophylaxis.
So, yes.
So I just want to add, if for during pregnancy, I think the only indication is when there is a history of venous thromboembolism earlier, which is unprovoked. For that, you need whole throughout pregnancy, antepartum, and also postpartum. And also, anytime patient is admitted long term for more than 3 days, we have to evaluate her for need for thromboprophylaxis.
Yeah, there are many risk
And
factors.
so there are many factors which is during pregnancy also.
So,
So
we
we
have
know
to
that
do
there
the
are.
risk stratification, ma'am. Does
Yes.
they belong to low
Can we
risk,
have the
medium
next
risk,
slide,
high risk?
Krishna?
Future slides.
Krishna, next slide, please.
I have put in the next slide, Dr. Sheila. Can't you?
No, ma'am, we are not able to see the next slide. We are able to see only the same slide, the question
Yeah,
slide.
yeah.
Yes.
Oh God, in between I played the other slide. Now can you see?
Yeah,
Yes.
you can see.
Yeah. So yes, Aruna, you can go ahead. Like you
Yes,
were
ma'am.
saying that.
Actually, as we all know, the pregnancy is hypercoagulable state, and the prevalence of DVT is 0.6 to 1.72 in 1,000 deliveries. 5 to 10-fold increase during pregnancy and 13 to 35-fold increase in the first week and 3rd weeks after delivery, 3 weeks after delivery. So it is common in first trimester and 3 weeks after delivery and returns to normal by 6 weeks. So we have to do the risk stratification by taking proper history, clinical examination and blood examination, then come to the conclusion whether to give it is necessary or not.
Yeah. Would anybody would like to comment about this?
So pregnancy, there is an increased risk because of the Virchow triangle. There is a hypercoagulability because of the increase in the factor 1, 2, 7, 8, 9, 10, and also there is stasis because of the effect of the hormones, and also because of the gravid uterus pressing, and also there is endothelial dysfunction or injury at the time of delivery. So all these three together make a pregnancy, the risk becomes almost 5 to 10 times of a non-pregnant condition. The risk of
And I
thrombosis.
think today, all the more, with the changing lifestyle, with obesity, and with increase in the incidence of NCDs, I think there are more contributors now for this factors where there is a exaggeration. Yes, next slide, please.
And age is also one factor, ma'am. If she conceives after 35 years, the risk is more.
Age
Yes, very true. Yeah. So there is a 3-step approach. Yes, Rekha?
Yeah, sorry, madam. We can think in terms of, though pregnancy itself is a problem, we can think in terms of additional risk factors like pre-existing factors, obstetric factors, and other additional transient factors.
So that is why there should be a screening for every woman at if there is an increased risk, we should stratify them, as Aruna was saying, that whether they are mild, moderate, or high risk. And then we will have to start the treatment with the right drug to the right dose for its right duration, because we have to give anticoagulant, so we have to know it correctly. And is it different now? Is it different, Dr. Priya? Dr. Priya, would we like to comment about this? Is the management in pregnancy is different?
Usually, madam, if the patient is already on warfarin, okay, it depends upon what condition she has. If she has a very high risk for cardiac, we don't change the warfarin at all. We allow the patient to continue throughout warfarin. If a risk for pulmonary embolism or a right atrial thrombosis, for example, if she has a atrial fibrillation along with that, then we don't change it at all. We continue with it. Suppose if the risk is not that much, then we try to change it to low molecular weight heparin in the first trimester, and then we try to change it back to warfarin, and when we anticipate delivery after 36 weeks, we try to shift it back to heparin. So this is a
that is one example. So because it has teratogenic effects as well.
Yes.
As well as, we are dealing with all high-risk patients, so there is unpredictability of onset of labor.
Yes.
Then the patient can go in labor and she may require analgesia, anesthesia, where she is on anticoagulant, that is a risk. And of course, there are many peripartum issues, Like most of the time, as we said, that the incidence is higher there, particularly the postpartum. Okay. Yeah.
And the dose we calculate based on the weight of the patient as well as the risk factors, madam. Whether you want to give a prophylactic or a high dose prophylactic or a therapeutic dose depends upon what condition we are treating them for.
Yeah, very true. Very
so
true.
we have to have an ideal anticoagulation, madam. Like we should be able to predict the anticoagulation, the bioavailability level. Quick on and off should be there. That means the short life should be there, and we should be able to monitor the side effects and we should be able to reverse it.
We should also
it should
know
be
that.
zero effect on the fetus also.
Yeah,
And
very
some
true.
drugs like direct thrombin inhibitors and anti-factor XA inhibitors, they are contraindicated during pregnancy. So some drugs, novel drugs are contraindicated. So we
Okay,
have to
next,
avoid them.
next we can go to the cases now. I think we'll go to the cases so that we can have better discussion there.
Yes.
Next, Dr.
I
Krishna.
just, yeah,
Yeah.
I just wanted to add one word. So warfarin, shifting to warfarin in the second trimester for low risk cases is not necessary, but it's more of convenience. And because even warfarin causes more of placental hemorrhages also. So it is not by choice that we shift to warfarin, but if the patient is not it's comfortable because of taking the medication or because she is having affordability is the problem, then probably we might shift to warfarin. And of course, if you're looking at shifting back close to delivery, then better to shift to unfractionated heparin
Unfractionated. Yeah.
rather than low molecular weight because it is more rapid acting. So this is one thing I wanted to add.
I just even counseling is very important, maternal counseling, because she should be told what is the side effect of warfarin, and mother should decide whether she wants to switch or so. With both pros and cons have to be counseled, told to the mother, then she should make the decision. And our counseling should be more towards switching from at 6 weeks from warfarin to low molecular weight heparin in first trimester.
Teratogenicity and placental abruption, two important problems with warfarin.
Correct.
Yes. 25 years ago.
So we are having a scenario where this is a 25-year-old, 8 weeks pregnancy. The BMI is 25. And as you all know that it is a very, very
low
risk
pregnancy.
Low risk pregnancy, yeah.
So low risk, we have done the risk stratification. But
It's zero.
there was one case which we had. So let's have a discussion on this case. This is a 28-year-old Gravida 4 para 2 live 2 with one abortion and 2 previous cesarean sections. One day she came in the morning hours with 2 months of amenorrhea and vomiting since 2 days and seizure episodes since morning. So she was asymptomatic 2 days back, then had 8 episodes of vomiting with food as content and no pain abdomen, no loose stools, no other medication she was on. And they thought she is hyperemesis gravidarum in a local hospital, after which she developed 3 episodes of seizures since morning. And then she came to our ER with 4th episode, a generalized tonic-clonic type of seizure with no loss of consciousness but confused. So there are no other associated phenotypically abnormalities. General examination was except for pallor, nothing significant. Even the vitals and systemic examination were found to be normal. There was per abdomen, there was just a scar present. Uterus was 10 week size, soft, mobile, and with no other adnexal masses or tenderness. CNS examination showed that she is conscious, irritable, not cooperative. Bilateral pupils were normal, reactive to light, responding to verbal commands. Cranial nerves, when examination was normal. The Glasgow Coma scale was 15 by 15, and the power in both upper and lower limbs was 5 by 5. Deep tendon reflexes were normal. So now, can you think of a differential diagnosis for this case?
Yes, there are
You can
two
change
things.
the slide, Krishna. Yeah, we'll go
Two
ahead because only
two
30
things
minutes
to
for us.
think
Yeah.
of. Yeah, one is the essential seizure she had before pregnancy itself, the epilepsy one. The second thing we can think in terms of cortical venous thrombosis also in these cases, cerebral venous sinus thrombosis, I mean. So then we have to rule out other things like infection, as you have written, meningitis, and those are the subsidiary. Next, my mind will think of those differential diagnosis.
So now she has a combination of both, vomiting with seizures. So there was all of those, we have narrowed down to probable CNS causes, dyselectrolytemia or eclampsia.
No, unlikely eclampsia because she's
The
just
early trimester.
Atypical.
So I think here the thromboprophylaxis should be considered because she has been admitted and she's quite sick. So anytime patient is admitted, it becomes a...
Ma'am, I will, like, without knowing the cause, if it is already hemorrhagic and you're going to give her thromboprophylaxis, she's going to bleed more.
Yes.
So without knowing the cause, we will not start her on thromboprophylaxis. I think a CT brain for her will be the best one. If you have a facility
See,
for
she's
MRI, then okay,
Yes, Priya.
otherwise we'll go ahead.
we can
Yeah,
get the
agree
MRI
with you,
done.
but I think
CT will
MRI
not
should be
do.
done.
10
MRI
weeks.
can be done.
In
Yes,
many
better than
hospitals,
CT.
MRI are
not
not available, madam. Even in our
Serum
place in
electrolytes.
emergencies, we have only the CT to be done. So I think with the shield and other things that, the exposure you can explain. And when it's life-threatening condition, I think you can still do a CT at 8 weeks. It's not going to harm much.
Serum
CT of the
now
brain for the baby.
now you can look at the investigations, what was done, and it has shown that ABG has shown metabolic acidosis, and TSH was surprisingly 0.016, and ultrasound was showing gestational age of 12 weeks. Then of course, I agree that CT is the one which is easily available, but the first choice definitely is MRI. Yeah, so this is the MRI picture with the hemorrhagic transformation in right frontal subcortical region because of CVT, and cortical laminar necrosis in both the frontal lobes with chronic ischemic changes. So now anything else you would like to do or stop here?
I would like to do the serum electrolytes also in this case to rule out
MR, if it is
hyponatremia.
MRI, are you meaning the MR angiogram, madam? You want to do the put a dye and see the MR angio? Is it what you're asking?
Yeah, so we have done the MR venogram, and not me, the radiology department. They have gone ahead
Yes,
and
ma'am.
done the venogram, and this is the MR venogram report, which says that there is venous infarct with hemorrhagic transformation in right frontal subcortical region due to CVT, and it is the superior sagittal sinus and right transverse sinus which are likely thrombosed. And fortunately for her, the other inferior, the smaller sinuses are all normal, and the deep venous system is also normal. So
I
this
think-
is one positive finding, negative finding with a positive touch to it. As far as severity is concerned, the prognosis is concerned.
So I
think
will
that's
consult
like-
a neurologist in this case.
Yes.
Exactly.
Complicated to be handled by.
Definitely. Definitely. That is what I wanted to tell you. You need to have a multidisciplinary approach. Remember, the patient was still in the ER, where everybody, all of us were there. So it's not only the obstetricians. Then what are the other investigations? Would you like to do anything else? I think we just heard Dr. Ashish talking about APLA.
APLA we usually don't do in pregnancy. It's not report is not very reliable, so it should be ideally done 12 weeks post.
Actually, the ACLA, the anticardiolipin part of APLA does not differ in pregnancy, madam.
Yes.
So that can be
So
done.
we can
But
do that.
LAC
Yes.
and beta 2 will differ in will be like abnormal in pregnancy. But ACLA can be done. ACLA can be done.
IgG.
So, as you all rightly said, APLA is better diagnosed in between pregnancies, but if necessary, when we have
can do
many a times we are doing them even in pregnancy, more specifically the ACA. Okay, then the other
ANA
investigation
for
a negative. ANA was also found to be negative. The homocysteine levels were within the normal range. The coagulation profile, LDH, and fundoscopy was advised. So we have a case of Gravida 4 para 2 live 2A1 with 12 weeks gestation age, seizures due to CSVT, and de novo hyperthyroidism. So anything, what would be your recommendations for this patient be?
So this is hyperemesis induced.
Or a very low TSH, you must explore.
But this is because of hyperemesis, which can cause the transient hyperthyroid-like picture. So
Hyperthyroidism,
if you correct the patient
Correct.
with the electrolytes and like a fluid hydration, most of the time the thyroid may get corrected on its own. So if the patient is not having a symptom of thyroid storm, I don't think we should address the thyroid now. Maybe once the vomiting settles, we can repeat and recheck the thyroid values.
Yes, I agree.
In case of, she had mild metabolic acidosis, which was also corrected.
And in first trimester, TSH may be low because of the
Yeah, that is what. Yeah. But as the patient is now not conscious, we have to think of thyroid storm also, as she rightly pointed out, because the TSH level is very low, and definitely the treatment of convulsions now, because the patient has presented with convulsions. So I think Dr. Krishna, I think anticonvulsants were started.
Positive finding on MRI. We have a cortical venous thrombosis, CVT on MRI for the, so that points towards the cause of a fit in this case.
Yeah, patient was started with anticonvulsants. Patient was started with her metabolic acidosis was corrected. She was also advised to start on ecosprin, and of course, low molecular weight heparin was also started once the diagnosis was confirmed. And parallelly, they started on tablet carbimazole also. And now, what is the option?
Why do you give both the anticonvulsants, magnesium sulfate and levetiracetam?
No,
because
well,
one would have been sufficient, right?
I
think both are different
levetiracetam would have been sufficient, I think.
Yeah, levetiracetam for the first trimester,
In
I
this
think.
patient, levetiracetam.
What is the indication of giving
What
both
happens?
the convulsants?
Listen.
Any patient, first time when she presents to us, we do start with magnesium, because till you get a MRI done and anything. But early pregnancy, I agree with
This is
Sumana.
12 weeks. Why?
I would like
Less than
to
20 weeks. Why?
Aruna, that's what I'm trying to explain. See,
Okay,
magnesium sulfate, like you rightly said, first trimester, with hyperthyroidism, epilepsy, eclampsia can be there, severe preeclampsia can be there. We never know what it is. So for a single dose, the loading dose of Maxelf was
IV dose was given.
Yes, given. Then afterwards, after we got the picture, in the parallelly, the neurophysician also started levetiracetam. And then after we realized we didn't follow up with, when we got a diagnosis, then definitely magnesium sulfate was not continued.
Because,
Okay,
because the concrete diagnosis was made, it was withdrawn.
Right, exactly. So now what would be your obstetric advice to this particular patient? How would you what do you plan for this patient?
This patient, I think she should continue for this on heparin for at least 6 months, because after any event, it has to be continued for 3 to 6 months in consultation with a neurologist in this case, and also postpartum 6 weeks.
Till delivery.
It has to continue.
No, this patient will require it
I think should continue throughout pregnancy and postpartum.
Until delivery.
Lifetime.
Throughout. She will require it throughout.
So throughout pregnancy
and 6 weeks post-delivery.
Postpartum. Yes.
Throughout and 6 weeks post-delivery.
This is not the case where we can recommend warfarin in the postpartum period. This is to be continued lifetime.
Yes.
So fortunately for us, the patient had 2 live children and she opted for a termination of pregnancy. So the anticoagulants were stopped. And of course, the neurophysician has advised on continuing with low molecular weight heparin and ecosprin. Patient has chosen to go for a suction evacuation and tubal sterilization. We stopped her on anticoagulants. We did it parallelly. And patient continued with the medications. And like we all have said, that pregnancy and puerperium again are important risk factors, where 20% of CSVT cases are diagnosed. And most of the CSVT, unfortunately, are in women because of whether it's contraceptives, pregnancy, or puerperium. And it's that itself, I mean, there are many risk factors which add in the pregnancy. And the standard treatment in the hyperacute phase is subcutaneous low molecular weight heparin with the dosage given twice daily, as Dr. Ashish has already said. And any procedure you can discontinue 24 hours before and 4 to 6 hours after vaginal delivery, or 6 to 12 hours after either C-section or suction curettage, and continued for at least 6 months postpartum. I think the prognosis is variable.
I think very important. So I think, Dr. Krishna Kumari, the message is even hyperemesis gravidarum cannot be taken lightly. If your patient is not responding and she is dehydrated, she will be prone for CVT. So it is very important. I mean, even hyperemesis also should be monitored properly. I mean, that is the message, because she can have a dreaded complication. We have only 18 minutes left, I think. So
So
Yeah.
hyperemesis is also indication for thromboprophylaxis, I think. The message goes.
Cortical venous thrombosis is secondary to
Then
hyperemesis because
could
of
have prevented
dehydration
this
in this case.
by
Yeah,
Yes.
that is the question now.
again same one. Yeah,
Yeah.
could have prevented by giving thromboprophylaxis in
But
time.
So
more
it's
than
not
that, hydrating the patient and maintaining the electrolytes and monitoring her diet and fluid intake, sometimes needed IV fluids also will maintain her hydration, which will prevent the cortical venous thrombosis in this case.
So it's not enough if alone if you do the risk assessment right in the beginning of a pregnancy, but also should be repeated. So any
Yes.
reason she is admitted, any reason she is developing any intercurrent problems in the pregnancy or in the interpartum immediate postpartum period, especially admission itself is a mandatory to assess for the risk factors for all these patients and have a risk stratification score. I think all of us know about this risk stratification score regarding the Dr. Sheila, would you
Yeah.
to take over
These
and comment?
are these are the risk factors now. Like if there is a pre-existing, and I think the score is given on right side. So where there is a thrombophilia which is heritable due to antithrombin deficiency, protein C deficiency, protein S, factor V laden mutation, maybe between 1 to 3, and prothrombin gene mutation, and acquired APLA. And if there is persistent LA and or persistent moderate high titer of ACLA and or beta-2 glycoprotein 1 antibodies are present, definitely they come into very high risk category because the score is 3 to 4. And acquired, as we discussed, the age factor, the obesity where BMI is more than 30, parity with smoking, and gross varicose veins. See, now varicose veins we see very often, but gross varicose veins where associated symptoms are there. And like medical cardiac comorbidities, we know like cancer, heart failure, active SLE, comorbidities, inflammatory polyarthropathy or
mellitus.
IBD. Yeah, diabetes mellitus, even type 1 with nephropathy. Okay, nephrotic syndrome, sickle cell disease, and current intravenous drug user who is continuously on some therapy or something. So like that, if we know that these are the risk factors, then definitely, so history taking will definitely play a very big role here, because sometimes people try to hide. I had one patient. Somebody asked me, I'm referring, you can do. When I asked her, she had a history of DVT. Okay. So before pregnancy. So like that, history taking becomes more important. Next slide, please. In
Yeah.
ART pregnancies, now Dr. Rekha is there. Yes, Dr. Rekha. Next slide,
Yes,
please.
madam. Yes, madam. I totally agree with you that there are a lot of risk factors in ART pregnancies, and the ART pregnancies are on rise, and so the thromboembolism.
We can have next slide, Krishna.
The first problem itself is the immobility of the patient. Once they get pregnant, they become invariably immobile, including the family member support. Pregnancy itself is a risk factor. Third, most of the cycles are frozen embryo transfer cycles where we give a lot of estrogen to build the endometrium. That also is a thrombogenic factor. Other than that, the factors like obesity, age of the mother, invariably these patients who come for ART are aged mothers. Associated comorbidities also like PIS.
And I think OHSS, no? OHSS, once they develop, they are a very high risk.
Yes.
So whenever
and
the risk
pregnancy,
four
multiple
and-
pregnancy, and the OHSS. These are all the problems that can add to increasing the incidence of thromboembolism, especially in ART patients.
Yes, Dr. Lavanya, we would like to hear from you. Now, there is a 36-year-old IVF pregnancy with twins, and she is also admitted with severe preeclampsia. And we have the risk score, and already we have calculated the score because her age is more than 35. It is IVF, it is twins and PE.
And severe.
Okay. So she has, so how would you like to manage now this patient?
So almost the score is 4+, and we are very clear that the prophylaxis has to be started definitely because she's high risk for thromboembolism. So we need to, depending on the gestational age, we should start with low molecular weight heparin if it is in the first trimester. And continue.
No, it is first trimester only because they will come to you. I mean, you have diagnosed now, you have all. Yeah.
Already admitted with severe preeclampsia, probably she might be in first trimester or second, whatever it is. We have to start her on low molecular weight heparin and continue throughout pregnancy until delivery.
And 6
my-
weeks
Next slide.
postpartum.
Next slide, Krishna.
Yeah.
Yeah. So it has to be continued throughout the pregnancy, and also I think post
6 weeks postpartum. Any
post-operatively
patient,
also, yeah, we will have to continue that. So next case also again IVF pregnancy with OHSS this is. Okay. So OHSS goes score with 4. Okay. So I think we would like to start if the patient has. Now, you know, in these slides, we are seeing that long distance travel. I think nowadays we get patients, you know, who want to travel during pregnancy also because they want to. I think all different lifestyles have changed so much and they will insist that, and that too they would like to. So if the travel is for more than 4 hours, you know, it is a risk factor. And for these patients,
she's 28 weeks. I think we can start antepartum prophylaxis and continue 6 weeks postpartum in this case also, because she's score is 3. So we have to start beyond 28 weeks. She already 28 weeks.
And proper hydration,
She has just
graduated
only one
elastic
factor.
compression is also
Yeah.
important. We have to advise. We
Graduated
have to
compression
advise
program.
movement also when she is sitting for more than 2 hours.
Yes.
And hydration.
Hydration
and last, if you notice, don't give her load of aspirin for thromboprophylaxis if she is traveling associated with air travel. Okay, that is there. Only I think we can start her on this LMWH.
Blockings are best for her for the short, if it is not at high risk. If she is at very bad risk, yes, we have to go with LMWH.
Yeah. Okay. Next. She is a primey again, 33 years, BMI is 26, 30 weeks, and admitted for preeclampsia. Okay. Her score is between 2 to 3. What do you think?
So
She should
if
be
the
offered.
patient is admitted, then during the period of admission, we try to give thromboprophylaxis. But once we are planning to discharge and continue the pregnancy, I don't think we have to continue with the thromboprophylaxis for her. And the second one is like if the proteinuria is there, if it is nephrotic range, then the risk of DVT is very high. Then if it is a nephrotic range proteinuria is there, then we have to continue the thromboprophylaxis till delivery. Actually, we'll try to deliver them early when they have that range, because usually the impact on the kidney and for them progressing into a renal disease is very high when the proteinuria is high.
But do you think we should continue with LMWH? Yes, Krishna, I think with nephrotic changes.
I think we go
nephrotic changes, yes, ma'am.
UFH is better because it is metabolized both from liver and kidney, whereas LMWH is metabolized only in the kidney. That's
Yes.
why whenever there is a kidney issue, we prefer the UFH to LMWH.
I think the message is clear. So you have to look at nephrotic changes in preeclampsia particularly. And these will be there even with patients with SLE also, you know, like they also come under high risk. So you will have to rule out because, you know, those patients will also have nephritis, exacerbation during pregnancy. And if they are on LMWH, we'll have to be very careful. And there are other types of anticoagulants. We will come to that, even we can do that. Okay, next.
I think for this
this is
patient also, madam, we have to do risk assessment at the time of postpartum and also at the time of discharge, because she's a high risk case. So we have to do risk assessment for need at these two places also, immediate
Yes.
postpartum and at the time of discharge.
Yeah, very good. I mean, that means the risk assessment does not stop. You just do it and leave it. You will have to go on doing it successively. All the more if she develops more and more complications, because even liver also, if there is a problem, you know, you can't give this LMWH. So you will have to be very careful. Okay, can we go to next slide?
Yeah, I've come to the next slide. You can
Yeah.
make a comment on that.
Yeah, so this is how, you know, again, there is antenatal assessment to be assessed at booking and repeated if admitted, what just now Upama, I think, mentioned about it. So hospital admission, history of VT, high risk for thromboprophylaxis we should have. And then if they have comorbidities, like I was just mentioning about SLE, IBD, or even inflammatory polyarthropathy, I think we already covered this, okay? I think the previous slide, there is almost a repetition. Okay. But if there is a low risk, you know, mobilization and avoidance of dehydration is the advice. Okay. So, I mean, it is not that.
Are less than 3. When the risk factors are less than 3, Yeah, that means it is lower risk. Then you can go for mobilization and avoidance of dehydration.
Only for thromboheparin in low score people.
So what are the thromboprophylaxis? As you can see, I think this slide became a little haphazard. So you can see how the thromboprophylaxis goes. Score 0, no thromboprophylaxis. 1, no, also no. 2, it is short term. And it continue if after delivery for 7 to 10 days. If it is score 3, you start at 24 to 28 weeks and wait till and continue till 6 weeks after delivery. If it is more than 4, you start right at the beginning of pregnancy and go up to 6 to 12 weeks of postpartum, and very, very high risk, high dose antepartum with prophylaxis and at least 12 weeks of postpartum prophylaxis.
Yeah. So very clear now. 3 means we can start little late, but 4 we will have to start as soon as we have assessed it, right? And choice of anticoagulants, we have indirect thrombin inhibitors like UFH as well as LMWH, and synthetic heparin, pentasaccharides. I think this time, most of the time, we will be involving the vascular surgeon as well as the hematologist and everybody here. Then orally administered factor Xa inhibitors are there, direct thrombin inhibitors, and vitamin K antagonists like warfarin. Okay, usually we find the patients with wall replacement on warfarin, those who are coming to us actually. And yes, mechanical, very important, graduated compression stoppings, flow-trans pumps, intermittent pneumatic compression, and IVC filter. Particularly IVC filter is also important because if there is a deep vein thrombosis, in that case, it will be very important that we may have to put the IVC filter. Next.
And I think DOACs are not used in pregnancy, although we have used them, this Elquis and all during COVID time. And now we are not using any of these DOACs because there is no enough data.
Yeah, dabigatran and is not used.
And there are more of complications with that.
Yeah, so it basically leads to abortion, anomalies. So it's not considered
But
to be safe.
DOACs are B category as of now, but data is not sufficient. And although they have said they are more of what you call congenital defects, they are lesser than warfarin. They are found to be lesser than, and there is nothing specific that they are identifying because of DOACs. That is what is the
So
problem.
we don't have enough data at present. Maybe down the line we may safety profile may come.
So like we already said, low dose aspirin is not recommended for thromboprophylaxis, and this is
graduated compression stockings.
Yeah. So the choice between UFH and LMWH we have already, I think, discussed. When we use the only advantage of UFH is that when it has a shorter half. So when we are expecting sudden labor or something, you can shift to, and if the patient needs she's at high risk, you can shift to UFH.
And even if there is a CKD, you can use UFH, but not LMWH.
Less than 30 ml per minute,
Yeah, CKD you can use it. And the advantage is like you are shifting, you don't know, like you have to stop and then shift to UFH, and then you can wait for 6 hours and take the patient for delivery or cesarean. So that risk will not be there. And the reversal with protamine sulfate is preferred.
That is
and APTT we have to monitor in them. Okay.
Yeah, we can monitor it, whereas this is just this slide is only to say that
Dr.
it is.
Sheila, you'll have to wind up in 4 minutes.
I know, Achila. That is why we are running.
Yeah.
We have to do the post test also.
I think this slide is important. Krishna, we can discuss this.
Yeah, this is the dose of enoxaparin.
Okay.
Yeah, if somebody wants to take it, it is again depends on the weight of the patient.
Depends upon the weight of the patient. If it's less than 50, if it is enoxaparin is 20 milligram. Usually we get enoxaparin only in most of the setups. So if you can memorize only that, it's good enough. There are few centers which use dalteparin and tensaparin. So if it is 50 to 90, it is 40. So usual doses, most of our patient will fall between the 50 to 90, this one, 40 milligram.
That is a
prophylactic. We are talking about only prophylaxis.
Yes, we are talking about prophylaxis. prophylactic, yes.
Right,
And for a low risk prophylactic dose, if it is more than 90 kgs, maybe most of them will be less than 130 only, it will be 60. If your patient is extremely obese of more than 130 kgs, then we can go with 80. This is low dose prophylactic therapy. And whenever we talk about high dose prophylactic therapy, is nothing but therapeutic dose or 75% of the therapeutic dose, which means you can either, therapeutic is nothing but double the prophylactic dose in most cases. So if you want to give 40, then you go with 80 is the therapeutic dose, and high dose prophylactic is go with 60. Increase that. 75% of the therapeutic dose is high dose therapeutic, high dose prophylactic dose.
A
And by
therapeutic,
intermediate
simple ways,
dose,
1
we
milligram
may
per kg twice daily.
Sorry?
1 milligram per kg therapeutic dose is easy to calculate. 1 milligram
Yeah,
per kg.
yeah. That
twice
is how
daily.
we calculate.
Easier to remember. Easier to remember.
when we are giving a high dose, we give it BD dose. When we give a low
Divided.
dose, when we give a low dose, we give it in a OD dose.
Yes.
And in between is the intermediate dose. What we mean by intermediate dose is a dose which is adjusted to the gestational weight gain of the woman. That is what they mean by intermediate dose. So what we normally have is the low dose and the high dose. The low dose being for the which OD dose, and the same dose when you double up, it becomes a high dose. That's it. So these are the contraindications most of us know. I think we'll skip this slide. Side effects, we expect this bleeding, hematoma, and if you don't treat it, she'll land up with pulmonary embolism and all. So that is also worse. So you have to take a balance. And these are the other drugs which are available. And we have newer drugs, DOACs, and one, I think this one you have to take management during labor.
Yeah. I think again, when we come to labor management is very important, because they may go into preterm labor, may require urgent. So women on LMWH, they should not be advised to take any further injection if they have vaginal bleeding or once labor begins. And it has to be discontinued if we are planning for induction or LSCS. But in high-risk patients where we cannot stop, like those who had a VT during pregnancy instead of a history of VT, and they were already on. So in those patients, we shift to EFH. I think we just discussed it. Okay. You can almost go up to 5,000. Yeah. And another thing is this, because if we use regional anesthesia, we will have to avoid it for 12 hours after the last dose. Again,
And
catheter
removal
also.
again for 12 hours,
Yeah.
it should be avoided.
That gap of
I think, yeah, but these are very important, because so many times, I know these patients will be in HDU only because we don't keep them in a regular ward. So post-operatively or post-delivery. And another is the postpartum risk assessment, which is again, because as we said that it is more common postnatally. So we will have to see, again, same criteria come here. But suppose if there is a patient who had a postpartum hemorrhage or a more bleeding of 1750 ml, and we have given 2 PRBCs, again, what happens? There is a 2 to 4-fold increased thromboembolic risk. Immediately, we may not, but the next day, I think once the bleeding has stopped, we may have to assess this patient, because cesarean section itself, again, can become a risk factor. So we may have to just start a prophylaxis for this patient.
Yeah,
Okay.
emergency cesarean section.
Yeah.
Madam, can we conclude now? Because 7 o'clock.
So the other measures, one message I want to give, prevention of dehydration. Because, now when we do the maternal death review, what we find, and I must share with all of you, that is why the Karnataka government has come out with a policy now. Because, the patients come to Taluka district hospital and they are discharged early and they are not monitored. And if they have a high risk like PPH or PET or anything, so now there is a direction that they should be discharged on 7th day only. That is because they are monitored in the hospital. Another thing is the hydration, because, there is a trend here, at least in South India, that they don't give them enough water somehow, postnatally and post-delivery. So that habit has to be broken, and ambulation, which is very, very important. All of us, we know that. And I think all of us are quite vigilant and we are practicing that. But, the deaths, embolism, when it happens so suddenly that most of the time we lose the mother. So I think a risk assessment, again, intranatal, postnatal is equally important. And we will have to continue the thromboprophylaxis depending on the I mean, the risk even post-operatively. Yes,
This
only
is
2 minutes left.
I think
Krishna?
now we will go to the
Yeah,
post-test. I think wonderful discussion and very good take-home points. But
just give us 1 minute. We are closing, Dr.
because it's
Achla.
already 7:05 and then 15.
1 minute, 1 minute. Yeah.
Okay, 1 minute.
Yes,
So
Krishna.
this is a second gravida who has come with post-cesarean pregnancy 15 days later with swelling of the leg. The message with
scenario.
there is no questions, please. We are only answering. So everything else was normal. A Doppler showed that there is a thrombosis involving left common femoral vein, superficial femoral vein with thrombus extending into great saphenous vein. So here the algorithm goes like you do the best investigation would be a compression
Doppler.
ultrasonography and see what is known as CUS and a chest X-ray. And when this was done, these are the time D-dimer less than 500 has a good negative predictive value, but in pregnancy there is not much of use by doing a D-dimer assay. And the best test would be go along with the, I think this is the right side. If you look at it, every patient where there is suspicion, do a duplex ultrasound or compression ultrasonography. If it is positive, start on anticoagulation. If it is negative but there is still clinically a high index of suspicion, especially of the iliac veins, you start off empiric anticoagulation and do a MRI venography. And if there is a low index of suspicion, don't start treatment, but repeat the investigation and serially day 3, day 7. If positive, treat. If negative, no treatment. So that is what you can do. And this is the closing remarks. And we are concluding with saying that knowledge regarding thromboprophylaxis in obstetrics is mandatory for all practicing obstetricians, and be aware of all that is required. A big thank you from my side, from both of us. And I'll leave it to Dr. Sheila to close the
Wonderful.
session.
Yeah, I think we are closing, Achala. Thank you very much for giving us extra 1 minute.
Yeah.
And I must thank all the panelists,
Wonderful.
Upama,
All the
Aruna, Priya,
panelists were very
Lavanya, and
nice.
Rekha.
Thank you, respected moderators. It was a great panel. Thank you so much. Learned so much. Thank you.
Thank you, ma'am. Thank you for the opportunity.
Wish we could have gone on, but the time constraint. But it was really
I
very
think
well.
people are waiting for the post-test, Achala. I think we have to give.
Achala, thank you for the opportunity. Monica, Dr.
Thank you.
Shanta the Great, Dr.
Thank you,
Sheila Mane,
ma'am.
ma'am. Thank you so much.
Krishna ma'am, and thanks to all panelists for a wonderful panel discussion, which was like icing on cake for day 3. So
we will need half a day for this next time.
Thank you, everybody.
Ma'am, it is non-stop academics.
So
we are testimony to that.
The link, please.
Thank you very much. Thank you all.
Yes, ma'am.
Can we have the link for the post-test?
Yes.
Yes, ma'am.
You will all get certificate after you have given the post-test, and if you secure 50% marks, and if you have attended all the 3 days, you will get the post certificate. So you can scan this, or there would be a link in the chat box, and we have the link in the chat box also for the post-test.
Yes, ma'am. Already sent.
Yeah, post it again because I can't see it in the chat box.
Yeah, it is
Yeah,
there.
the link is there. Nice.
Yeah. So we'll wait for 15 minutes and then give you the answers. And while we are waiting, I think I must thank all the faculty, starting from the lectures about thyroid, chronic renal disease, very insightful psychiatric disorders, which are, rarely ever discussed, APLA, SLE, very good topics and discussed very well. And I think the cherry on the top was the panel discussion, which was really good. And thank you all the faculty for being part of this. And I must thank Dr. Parag, Dr. Sarita for allowing me to be the convener of this very important certificate course. And my coordinator, Monica, needs to be really thanked for all her hard work, and not to forget the background team of ICOG, Nilima, and everybody else who really let everything go without any glitches, effortlessly for us, that it goes on, everything goes on so well. So thank you, everybody. And I think we can all also.
I think we have to be silent for them to answer.
Pardon?
I think we have to be silent for them to answer. Otherwise, we will be disturbing them.
They are not listening to us. So finally, we are ready for the answers. Can you put up the answers, please? Meanwhile, while the answers are being put, I think I can. Yeah. I can start. Oh, okay, Shreya has already started screen sharing. Yeah. So question 1, prevalence of psychiatric disorders during pregnancy. C, 10 to 20%. Which psychiatric disorder is most common? Major depressive disorder, C. Untreated maternal psychiatric illness during pregnancy is associated with all of the following. There is neonatal hyperglycemia is not part of it. Which of the following psychotropic medications most associated with congenital malformation? B, lithium. Which of the following woman is highest risk for postpartum psychosis? Answer is C, a woman with a history of benign bipolar disorders. Which is the most common symptom of ISCP? Pruritus. Pruritus in ISCP most commonly affects which part of the body? Palm and sole. B, the definitive diagnosis for ISC is serum bile acid. C, which of following is the drug of choice for managing ICP? Ursodeoxycholic acid. B, which of the following is not a typical finding in a pregnant woman with CKD? That is increased urinary frequency. D. The other name of APLA is Hodges syndrome. A. Hallmark of APLA is pregnancy disturbances. Commonest complication of APLA is DVT-A. Drug effective for management of APLA is low molecular weight heparin. B. Screening for thyroid disorder in pregnancy should be universal. C. In the first trimester itself, treat all women except those with TSH less than 2.5. Subclinical hypothyroidism in pregnancy is seen in approximately 10%. C. Subclinical hypothyroidism is associated with all except renal disease. B. Fetal risk with overt hypothyroidism include impaired neurological development. A. SLE can produce following disease. Tick the wrong answer. That is SLE. What is it? Can you read, Monica?
SLE mastitis.
SLE mastitis. B. So that is the end. So you can mark yourself. With this, we end. Thanking everybody. Yes.
Thank you, Achla ma'am. Thank you, ICOG. Thank you, Parag.
Dr. Parag, thank you very much for being there at the end.
Thank you for the opportunity.
My computer stopped working, so I joined from my phone today. Anyway, good evening all, and thank you, Dr. Achala and Dr. Monica, for being here and managing the program so well. Thank you to all the delegates who have participated today. And just a quick announcement about the next program, because there was a question asked by many of us. So the next certificate course will be on abnormal uterine bleeding, and that will be on the 23rd, 24th, and 25th of July, Wednesday, Thursday, and Friday. So till then, keep learning and see you also. Thank you.
Yeah, thank you. Thank you, Dr. Parag.
Thank you, Parag, sir. Thank you. Thank you, Achla ma'am. Bye.
Bye.